This novel program initiated by Dr. Partha Bishwas for the first time in AOC, the teachers of tomorrow. So the TOTs, the tiny tots, who are our future ophthalmologists, the budding ophthalmologist, will now strive hard to make it to the top to become the best teacher. So for a change, they are going to teach us and we are going to listen to them. So we have, since it's a inaugural event for the AOC, we have right now 13 states who are competing. We have Gujarat, Orissa, Kerala, Bihar, Maharashtra, Jharkhand, West Bengal, Assam, Rajasthan, Delhi, Karnataka and Telangana. She is already taking. So we are just deciding the sequence so that it's a fair and square and the people representing one state. One student can come from a state and pick the lot to decide the sequence. Can you have the show of hands? Is Gujarat people here? Gujarat. Orissa? नहीं ये sequence नहीं sequence तो हम decide करेंगे. Orissa here? Even the mentors are okay. Okay. Kerala, I think they're all uploading the presentations. Kerala is here. Okay. Bihar, home state. Home state is busy with the Mehman Nawazi, I think. Maharashtra? Maharashtra? Okay, yes. Jharkhand? Jharkhand to nahi. West Bengal? Okay, yes, thank you. Assam? Yes, I know. Rajasthan? Delhi? Okay. Karnataka? Karnataka. Can you call Karnataka people? Telangana? Yes, I know. Can you do a favor? Can you just go call all those people up here that's going to start? They can load from here also. Huh? You know, no? The first floor. Yeah. So this show will be anchored by myself, Dr. Krishna Prasad and Dr. Gopal Pillai. And we have the honorable judges, the panel. Dr. J.S. Tityal, Dr. Jyotirmay Bishwas, Dr. Rashmin Gandhi, Dr. Kirti Singh, Dr. Partha Bishwas himself. Gopal.
So, my dear friends, this is going to be the inaugural event of TOT in AIOC, and we are going to blow away. I'm sure that Dr. Partha Bishwas is excited because he saw the TOT in our state and he said, this needs to come into AIOC. He immediately put this program on. So, my dear friends, so we are going to have this next 2.5 hours of non-stop action by 24 young and bright minds who will 26, they have come. Okay, 26 young and bright minds who have come from different states, and competitively they will be teaching us 4-minute small capsules. And you will just understand how each of these 4-minute capsules will be benefiting each of us in other domains of interests. So, can we have the lots here now? Are we? Yeah, we are taking the lots. Yeah, can Gujarat has come? I mean, do you have the list? Each state, yeah. One person from each state can come here to take the lots. Yeah. Kirti madam ka teaching, she is a PhD in teaching.
Okay, give me
We are going to have a very tough time. The technology of teaching is going to be in question. The technique of teaching is going to be in question.
ओपन करो
यही है
इलियास अग्रवाल
इसमें अपना स्टेट वेट का नाम भी डालना है क्या
नहीं
Which state are you from? Assam.
नहीं नहीं नीचे वाला हाँ ये
Assam is 11.
टाइमिंग क्या मैम
हाँ
टाइमिंग क्या है आपकी मतलब जो प्रेजेंटर करने के लिए टाइम क्या है किस टाइम
मतलब ये सबसे मतलब जो टीओटी
Telangana is 7, number 7.
9:30 पे है
अभी खाली है
9:30 पे क्या
Kerala is?
मतलब
Kerala is 12.
8:30 से 11:30 2 घंटे
Yeah.
का ना
हाँ
वो वाला है
इसमें होगा
हाँ ये वाला
10 is? Orissa is number 10. Yeah? West Bengal is number 6.
राजस्थान
You're from? Maharashtra is number 2. Gujarat came late, but they are number 1. The early bird catches the worm, it seems. This is number 13. Delhi. Delhi is number 13. You're from? Rajasthan is number 9. So how many more to go? Karnataka and Bihar, the host states.
what happened
this one
low vision aids is it playing well
क्या बन गया
So you want to talk about the
सर आपको बता देंगे सर आप जस्ट चाय पी के फटाफट आ जाइए सो दे आर गोइंग आउट फॉर ए नहीं कॉफी ब्रेक नहीं प्लानिंग द स्ट्रेटजी strategic planning so they don't want to do it before you because there's going to be a lot of fights and arguments outside the hall please all judges Dr. Vibhuti, can you do a favor? Can you be a judge? Yeah, okay. Dr. Vibhuti Sinha will also be the judge. तब ऐसे करना ऐसे host उसको चाय पिला के लेके आना जल्दी
3 घंटा बैठना है लेकिन विभूति will be able
No, he said. ठीक है, Vibhuti will be the judge. You can write their names. Take you. उसको पूछता हूँ मैं. इसीलिए डॉक्टर पांडव को मैं नहीं दे रहा हूँ. जो हाँ हाँ झारखंड तो नहीं लिया है. झारखंड टेक एक पिक. नीलिमा
Jharkhand.
टेक योर 1 2 टेक द टेक इट और एक होगा ना 3
Yes, sir. One more. He's having presentation.
No, and also, तू जाओ इसमें इसमें I'll lick the names मैं नाम लिख दूंगा मैं. You have a pen? Okay. Write in the order. Dr. Kirti Singh.
One more state is remaining, is it?
Huh?
One more state has to come.
2 states have to come.
Okay.
2 states.
Maybe let them decide.
Or we'll pick it up on their behalf.
Yeah.
Okay.
So
Karnataka.
number one was
Karnataka is
Gujarat.
4.
Yeah.
And remaining 5 is no, not Jharkhand. 5 is Jharkhand to liya na abhi. Huh? This is Jharkhand 5. ठीक है, इसको ये इसी लिख दो, इसी ऑर्डर में लिख दो. डॉक्टर जयेश टिटिया, डॉक्टर ज्योतिर्मय विश्वास,
Just a brief word on the judges. Dr. Kirti Singh is director of GNEC. She's a glaucoma consultant, and she's been in Delhi for the last 30 years. She trained from RP Center.
Rashmin,
Professor Tityal is heading cornea, and he's the chief of RP Center currently. Dr. Jyotirmay Bishwas is a legend in uveitis, and he has been in Shankar Netralaya throughout his career. And he has more than 350 publications in uveitis.
now we'll go.
And
Okay,
then we have
come back as quickly as you can.
Reshmin Gandhi. Reshmin Gandhi is a neuro-ophthalmologist. He is from Hyderabad, and he is one person who is running the iFocus program along with Santosh Hanover. So we have 4 wonderful judges here who are in different disciplines, teachers for a long period of time, and they will be judging you based on your quality of presentation.
Partha,
They
you
will
are
be
going to
judging
be
you
the
based
judge?
on the technology that you've used in presentation,
you'll have to
and
go on.
also the scientific methodology of teaching
तो है.
and how effective was the communication.
उसको भी दे देना.
Any innovative things that you are doing would also be looked at in the presentation for marking. So please always try to be innovative, try to be communicative, try to be, getting that point across to the people around. So may the best team win. KP, you can talk about the rules and regulations.
So I think it's a very fortunate moment that we're all here, and it should be equally, rewarding for all the youngsters here, because this is a national event, an event of national importance, and you are going to take part. Representing your state in a national event itself is an awesome experience. And for all of us here, we are going to nurture the talent that you all have. And this program has a long history. In Karnataka, this was started in 2005. We have been having it regularly. It went to Maharashtra and Kerala very successfully. And we have been really awestruck at the kind of talent pool that we have in the young generation. Some of the thoughts have been a lot brighter and more talented than the guest faculty themselves. So our future of ophthalmology is very safe. So let me just go through the rules. I think you already know a bit of it. This is going to be a PG lecture contest, okay, where you are representing a state, and the states are actually competing for the top post. We have top 1, 2, 3 prizes for the state. We collect the marks and decide the best state. Also the best individual speaker, 1, 2, 3. So teachers of tomorrow, as the name suggests, you're going to come and teach here. It's a 4 minutes of teaching. It is not your PG seminar. You are the person who knows the most, and rest everybody are your students. So the time is very well kept, so you are going to lose marks if you cross 4 minutes. So make sure you have a timer here. Just have an eye on the timer and try to finish well before 4 minutes, because there is 1 mark that is dedicated to finishing before time or just on time. We may give you probably 2-3 seconds of only. If you cross probably 3 seconds, you're going to lose that. So total marks are 10. So we have the marks which are going to be shown as a placard by the judges. So it's a transparent, okay, marking, evaluation. Everybody knows the marks given by that. And Dr. Neelima will be actually taking care of the timing as well as the scoring and the compilation of the results. So we have total 10 marks for the content of your talk. So how you cover the topic, the relevance of your talk to the topic, and what are the illustrations that you have shown, your diagrams, your images, videos, and the way you actually have covered it will be basically based out of 4, maximum 4, and speaking skills, basically your oratory skills, your communication skills, your body language, the use of props, histrionics, your teaching skills. Okay, all those will carry 4 marks. And if you finish before time, it is 1, which is probably the lowest hanging fruit. And one question from the jury. We have the judges. We have Dr. Pandav, Dr. Partha also joining us. So there'll be one question from the jury regarding that topic. Okay, and how you answer that. So that will also, so totally they will compile the marks for 10 and show, the judges will show their marks on the placard, and that will be compiled. And you have 2 people per team, so we will go through the same sequence. Now we have created a sequence. Do you know the sequence now? Do you have the sequence? So I'll tell you who are the states coming first, and you decide who is the person who is going to present first in that sequence. So the same sequence will be repeated after all the states are over for the first speaker. The judges are deciding the strategy. Once they come in, we'll start.
Okay, so Winston Churchill was a great orator. He once told that if I'm asked to give a presentation for 1 hour, I can do it now. If you want me to present it in about 15 minutes, I will take a week to prepare. And if you require me to talk for 5 minutes on that presentation, I will require a month to present that. And that is the essence of thought. So in 4 minutes, you have a topic in which 360-degree you need to cover and come on. And I think you must have all prepared really well and looked at your timings, looked at all the extra things that would be there in your presentation. So all that would be there. So let the judges just come in, and by the time, let the Gujarat team...
Just tell the sequence.
Yeah.
The sequence is, first is Gujarat, second Maharashtra, third Bihar, fourth Karnataka, fifth Jharkhand, sixth is West Bengal, sixth is Telangana, sixth is West Bengal, seventh is Telangana, then Rajasthan, Orissa, Assam, Kerala, Delhi. So we're starting with Gujarat and ending with Delhi.
Gujarat and Maharashtra, both the first speakers can come here. Right?
Start at Gujarat and ended up Delhi is the Modi's route. Okay, so have you loaded your presentations? There is no time wasting. You cannot come and plug your pen drive or start with your laptop. Everything has to be loaded before. And also don't waste time in searching for your thing.
So can the Gujarat, the first speaker from Gujarat can come here?
Can come here, and the second speaker will be ready on the other side.
No, second speaker means Maharashtra.
Maharashtra.
First
So
speaker.
We will you have to decide who is the person. Please come and take the thing here. When they're going on, you should be ready with your thing ready there. Okay, we're not going to waste time in between. So let the Gujarat person come here, and the Maharashtra, the second person can go there.
Let them introduce themselves.
Yeah, let them fill their comment. So you are representing Gujarat. Can you introduce yourself?
उस पोडियम का था
Can we have the mentor from Gujarat? Yeah, please come over, ma'am.
So,
नहीं, वो judges को. No, the judges बाहर ही है. Dr. Vishwas है. हाँ, नहीं, वो तो. No, I think he came. They're also coming probably behind him. Can we have the mentor from Gujarat?
who is the
Please
mentor
come
from
out, please
Gujarat?
come out.
Yeah.
We can have the other person from Gujarat also, the other mentee from Gujarat also to come over here. Okay, you both are here. You can probably tell something about your team, why Gujarat is the best. Come here, please.
Then you can introduce, when you come, you can introduce with your intro video. You load it?
Extroverts can introduce by the intro. Introverts can just use the mic. Ma'am, please.
Hello, I'm Dr. Ravija, and my team consists of Dr. Krisha and Dr. Pavan. We are here from Gujarat. We are representing Gujarat. And once you see the presentations, you'll realize why Gujarat is the best.
Thank you, ma'am.
So who is presenting first from Gujarat?
Krisha is going
Okay.
We can have the Maharashtra team also by then ready. They can have the intro when the judges come in. Dr. Maharashtra team, yeah, please come up. And Maharashtra has the distinction of having 2 mentors.
Wow.
Only one. Please. Chalo, come. You can just tell what about what's your experience being a
So
mentor.
to mentor Maharashtra team, you needed 2 mentors. Now that is really great.
I think we need to, because they are so overwhelming with their presentations and preparation, that probably we might need 2 mentors to balance the heat. Yes.
Okay.
And we have a potpourri with Dr. Anju Bansal, who is a DNB resident at Sarakshi Netralaya, Nagpur, and Dr. Prachi, who is a MS resident at BJ Medical, Pune.
Okay. All the best.
you,
So
Dr.
the first
Deepti
person can
Kulkarni.
stand here
Yeah.
and you can make ready your presentation. As soon as the judges come, we will start. Abhi bula ke laata hoon.
So then the third, Bihar will come on this side and the Karnataka here. Okay. So judges have finally decided the strategy, how to score and which shade should come on the top. Sir, Pandav sir, नहीं आप इधर आ तो दीजिए. सर आप placards. So let the judges take your seat. I'll tell you the rules. Dr. Kirti, please take your seat. We'll explain the rules. So the first rule for the judges is you have to sit through the program and hear all the 24 talks. And you have, because you are scoring. Okay, the judges who are sitting who are not get through the whole program, they're not marking because it will be unfair. So you 4 will be the judges who will be actually marking the rules, marking the students. Huh? 5. So Dr. Kirti Singh, Dr. Jayesh Tityal, okay, Dr. Bishwas and Dr. Rashmin Gandhi will be the judges. So we have decided the sequence. Now the Gujarat will go from here and next Maharashtra will be ready. Once after all the 12 states are over, we'll have the second candidate coming in the same sequence. So the marks are 4. The timing will be kept by the, fix it at 4 please. Okay. So that if, we'll just, there are the placards for the marks. The minimum what you can give is 5, maximum is 10. So can you give the mark sheets? Okay. So if you can see the mark sheet, the total marks is 10. 4 is for the content, how they cover the topic, relevance, use of images, videos, illustrations. Yes, sir, please. Huh? No. 4 is for the content. 4 for your speaking skills, communication, body language and things like that. 1 for finishing before time. That we will tell you. Anyway, if they cross time, you don't get that 1 mark. And 1 from the question, how they answer your question. So 4 plus 4 plus 1 plus 1. So total 10 marks. Once you compile each, you can show the show of placard, so that will be registered. Yeah, 4 plus 4, 1 plus 1.
1 she will keep, ma'am. That 1 of time she will keep. You don't have to keep, ma'am. It's okay. 1.
No, no, we will tell them, they will only show.
Okay.
So, no, if you have crossed the time, we will tell you, you don't add that 1 mark. Question is 1 mark. So you decide, son, no, I think it's 1 or 0. No decimals, 1 or 0. Huh? So, but we don't have the placards for the decimals.
Okay, 0.5 को sir आप 1 कर दीजिए. 0.5 or more would be 1.
1. Or you decide a question which they can answer. Okay, so Dr. Anil Radhakrishnan will also be the other judge. Can you give him another mark sheet? Okay.
So I introduce the other 4 judges. Dr. Anil Radhakrishnan is a cornea consultant, and he is from Cochin, and he is trained in LV Prasad. He has about 20 years of experience in cornea.
Laga do, laga do. Let it come. Yes, yes, yes. No, they will come as the second sequence. Dr. Partha, before we start, just a word from you about this whole event. You are super excited.
Yes, I'm super excited, and the excitement started when I went to the Kerala conference and I saw this phenomenal TOT program which Gopal and Krishna Prasad have put together. It was so engrossing, it was so fantastic that I'm sure the judges who are here today are going to take back memories for life of the presentations that these kids are going to put up. And I know that a lot of hard work has already gone into the presentation. I know a lot of things have been brushed up, and here we respect the mentors who have done their great job of brushing up the presentations of these guys who are the teachers of tomorrow. So teachers of tomorrow, we really look up to you to be the best teachers of tomorrow for Indian ophthalmology. So Indian ophthalmology is proud of you, and this is what we want, that as Indian ophthalmologists, you should floor the world with your teaching. Thank you very much.
Where is a timer? Where is a timer? No, can they see? Okay.
It will be displayed. Okay. So we leave the stage for the students to take over. So welcome once again to this first edition of Teachers of Tomorrow. All the best TOTs and the mentors. Let's let the science prevail. Thank you very much. Now, the first speaker, Dr. Krisha Amin.
Well, I expected the applause after my name, but thank you. Kemcho Patna, Majama? Well, today all of you are my students, and we are going to start with the first topic for tomorrow, for today, and tomorrow and forever, which is Phakic IOLs. I would like to start with by the saying that a good teacher is the one who can teach anyone, but the best teacher is the one who knows how to teach somebody who doesn't want to learn. In this today's presentation, we'll be learning a brief overview on the Phakic IOLs. Phakic IOL is an intraocular lens which is implanted in eyes with coexisting natural lens. It helps greatly expanding the range of refractive surgeries. As in the history, you can see it started as early as 1953 and is still evolving to date. Now, understanding the Phakic IOLs, we should know the types of Phakic IOLs first before knowing the current trends. So the anterior chamber lenses were first decided to be angle fixated and iris fixated. However, currently they are not in much use as they are now used for aphakic patients more. What we need to learn from this is about the ICL, the posterior chamber Phakic IOLs, which is the advent of ICL. ICL is implantable collamer lens. Now, collamer is a material which is a combination of porcine collagen as well as a polyhexamer. Okay? What are the advantages, you might ask, over the keratorefractive procedures of Phakic IOLs? First of all, it helps in treatment of high ametropia, which sometimes our LASIK refractive surgeries cannot contain. It also helps with low induction of higher order abrasions, retinal image magnification, high contrast sensitivity, as well as the most important part is that it's reversible. What are the special considerations that you must think about in patients you are thinking for this approach. So the refractive error and the correction range should be present. The corneal topography, specular microscopy for the endothelial cell count, the slit lamp and the fundus evaluation for some pre-operative considerations of diseases. What are the important values that you must be considering are the anterior chamber angle, the axial length, pupillometry, wide to wide diameter, and the anterior chamber depth. The recent most advanced is the EVO or EVO Plus. As you can see in the image, it contains a central port which helps with the natural aqueous flow. ICL implantation process is easy enough. However, the placing of foot plates in the sulcus is a very important and skillful process. The ideal candidates to be chosen for this are, the age should be more than 18 years or as we consider the range from 22 to 45 years. The stable refraction, which is less than 0.5 diopters change for at least 1 year. In case of poor tolerance to contact lenses or spectacles, patients who have poor candidates for the laser refractive surgeries, endothelial cell density, or no pre-existing conditions. Special indications are the most important in pediatric age group via considering the risk-benefit ratio. The complications, as you must all know from implantation processes, is a post-operative infection. However, for this, you need to consider anterior subcapsular cataract, subluxation, dislocation, as well as raised IOP post-operatively. However, concluding this talk, I want to know that the paving way of the future is a rocky road, but we are going through it, and it is a still long ways to end this journey. In this, we can talk that ICL and LASIK are two different ends of a coin. However, both are important and one cannot substitute the other. Most studies are required as the long post 5-year-long study has never been considered, so a safety index and long-term benefits are still away. I would like to thank everybody and say, one often meets his destiny on the road he takes to avoid it. Thank you so much.
Excellent, Dr. Krisha. I think the timer will be now at 4 minutes. There was a little problem glitch. So you had that advantage, but we're not going to consider that. Judges, please don't consider because there was a glitch at the technical side. So next will be 4 minutes. There'll be a bell that comes at 3, and there'll be a long bell at 4. You have to stop at 4. If you cross 4, even cross 3 seconds, you're going to lose 1 mark. Dr. Krisha will not consider that. We have one question from the judges. Can we have the mic for the judges, please? So one question, Dr. J. Stityal will be asking a question for Krisha. The next person is ready. And the mentees, you can use the collar mic and stay clear of the podium. You can also use the slide mover. You can use the pointer. Okay, you can be a teacher. You can come here and swarm the stage.
Yeah, good morning, madam. As a student, when you are taking your class, 2 things are very important. One, surgical techniques are available everywhere. The videos are there. I would have really interested to know what was the review of literature in this particular presentation, the historical review, and looking into its outcome, not only the visual acuity, the contrast, the glare, halos, how to correct those things, and particularly looking into the types of phakic IOLs. I would like to know, you have talked about posterior chamber phakic IOL, mainly you're directed towards the ICL,
Yes.
Implantable collamer lens. So what is the refractive index of this lens?
The corrective power of this lens, sir?
Refractive index of this particular lens.
That is a good question. That means you're listening quite patiently.
One question.
If to say, then I would say that because of the material is new and it is of 2 kinds, then there should be 2 refractive indices which should be present. So it is different than that of acrylic, but not that much closer to glass.
No, ICL is not acrylic lens, no? Acrylic
Yes,
is different, that is.
Sorry, sir, what did you say last?
Okay.
Okay.
I think if I would have been in your place, I would have said, sorry, my dear student, I'll go back and check it and come back to you and answer this.
Yes,
Sir,
sir.
आप पढ़ के आना बोल सकते हैं. Next class में you're going to tell me this.
I'll make sure,
ठीक है?
I'll make
ये भी
sure
मालूम
next
नहीं.
time I see you, I'll answer this question.
If I teach you everything, what will you read? Go and read and
Thank you.
Dr. Pandav, you had something to say? Okay.
Thank you. That was a good beginning. I think one thing I noticed was just a comment basically is your talk was very general, so we didn't know what was the focal point of your talk. In the beginning, you could have said that, okay, today I'm going to give you an overview of the optical correction after aphakia or whatever. So that we'll know, okay, we'll expect a lot of things in that. But then you are kind of split between the ICLs and also the other lenses. So there was a kind of a lack of focus on what you really want to convey. So that's my comment on your talk.
Thank you, sir. Thank you for that input.
Now,
So,
can we have the show of?
Can we have the marks, judges, for Dr. Krisha Amin?
You can
from
show
Gujarat?
the, yeah.
5. Dr. Rashmin Gandhi, 5. Can you note it, please? Nilima? Yeah, you're there. 5, 5, 6. Okay. Thank you.
Anil, 5.
Anil also 5. Okay.
So 4 5s and a 6. 26 marks.
Okay.
Krisha. Next
So
is
now over to Maharashtra. Yes.
Dr. Prachi from BJ Medical College, Pune. Over to you.
Yeah, they have the slide mover. They can come off the stage, off the podium.
Excuse me.
They can come even off the stage also. Okay. The next person get ready there on that side. Bihar, ready.
The mentors from Bihar and the Bihar team can get ready there. If there is an intro video, you can show it right that side. Okay, over to you, Prachi. Let the time start.
Then Karnataka. If Bihar is not there, Karnataka.
Good morning, everyone. The topic for today's class is diagnosis and management of early postoperative endophthalmitis. As you know that it's rightly said that keep your friends close and your enemies closer. So this endophthalmitis is one of those enemies. What is postoperative endophthalmitis? It is defined as severe inflammation which involves both the anterior and posterior segment of the eye after a surgical intervention. It comprises of 25% of all the endophthalmitis cases. Now, this endophthalmitis is most common after cataract surgery. Now, when do we suspect endophthalmitis? When a patient presents to you with severe pain, vision loss, then lid edema, corneal edema, hypopyon, anterior chamber reaction, and you cannot weave the fundus. Now, in such cases of vitreous haze, you need to do the B scan of the patient. In B scan, you can see that there are multiple vitreous opicities which are suggestive of vitritis and increased chorioretinal thickness. Now, this endophthalmitis has to be differentiated from a similar entity, which is a non-infective post-operative inflammation, that is a sterile endophthalmitis, also known as toxic anterior segment syndrome. Now, this patient will present to you with limbus to limbus corneal edema, and there will be a mild vitreous haze and raised intraocular pressure. But this condition dramatically responds to steroids. Now, this post-operative endophthalmitis can be divided into 3 types, that is fulminant, acute and chronic.
Audio, please. क्या हो गया?
Now, the endophthalmitis can be confirmed by obtaining a sample for microbiological evaluation. You send a vitreous biopsy for staining and culture. Now, once you suspect endophthalmitis, you need not to wait for culture reports. The objectives of management are to control and eradicate the infection, manage complication, and restore the vision. Now, the mainstay of medical management in endophthalmitis is intravitreal antibiotics. It is vancomycin for gram-positive, ceftazidime for gram-negative, and amphotericin and voriconazole for fungus, and dexamethasone. Now, the supportive treatment can also be given with cycloplegics and anti-glaucoma drugs. The mainstay of surgical management is vitrectomy. The indications of vitrectomy are that when there is no improvement after 2 intravitreal antibiotics, there is advanced stage of endophthalmitis, that is no fundus glow is seen, suspected fungal infection, bleb or trauma-related infection, and retained intraocular foreign body. The endophthalmitis vitrectomy study has guided us that there is no role of systemic antibiotics, no role of immediate vitrectomy for hand movement or better vision, and immediate vitrectomy is beneficial only with the vision perception of light. What can you do at your level? At your level, the proven benefit is with topical 5% povidone iodine, and also you can use preoperative, intraoperative, and postoperative antibiotic drops. So the take-home message is that all unexpected inflammation following an intraocular surgery be considered endophthalmitis unless proven otherwise, as it is rightly said that prevention is better than cure, and it is also a medico-legal aspect as an ophthalmologist. So prompt treatment and early diagnosis is essential. This is a topic which should be known by every clinician so that you should not miss even a single case of endophthalmitis. Thank you.
Thank you, teacher. Thank you, teacher Prachi. Now it's over to the, yes, sir.
So you mentioned about the obtaining vitreous samples. Vitreous samples should be sent not only for direct microscopy, it should be direct smear, culture, and polymerase chain reaction, because culture is negative in 30% cases. So culture is positive only 30% cases. So 70% cases you miss by doing a culture. So you need to mention that PCR, because these are students of the future. They should know the polymerase chain reaction of the intraocular sample.
So can you have a question, sir, for her? That was a question? No, you can ask a question.
Yeah, so it's a very difficult topic. Suggestions to the team. I think it's just not the student, the mentor also. So suggestion is that same, you should have a specific learning objective to the class. It was too wide a topic to be covered in 5 minutes effectively. Okay, and the question I wanted to ask is, yeah, for the team. I think it's for the whole entire team. The question I wanted to ask is that you had said the management, then why didn't you, what is the management guidelines for India perspective, which is different from the other countries? And what are the guidelines for India specifically? For management of post-op and up. नहीं कोई बात तुझसे पढ़ी है studies वो वाली तो पता चल जाएगा. Because you just quoted EVS study, okay? You didn't quote the other studies which were pertinent to our country.
Do you know any study which is pertinent to India rather than the EVS, which is pretty old?
Very large volume study in India.
European study.
India.
Any Indian study?
When you're giving guidelines,
it was conducted in Arvind Eye Hospital in 2014 to 2016, where they use intracameral moxifloxacin, and it has reduced the endophthalmitis rate.
what was the fallacy in that study? What was the fallacy in that study? In that Arvind study, which they have quoted moxifloxacin intracameral. Anyway, so it's just that when you're doing the class, you have to have the homework done before, and your content was little bit scattered because the topic was so wide. That's why.
I think we should own up the responsibility of giving the topics to them, because that is our guilt. That is our guilt. Sorry.
Okay. Here, you are the teacher and our judges are students.
Yes.
You are the students?
Yeah.
Yes. But like a very well-read student, our judges can ask you all these questions. No? Teacher, you didn't say this. Teacher, what about this one? You didn't mention this.
Yes.
So you have to answer like a teacher. Have you not read it? Have you not read the Arvind Eye study? Do you not know it? This is beyond the scope of the class, and next day I'm going to tell you. That's it. Stride on the platform, teach like a teacher.
Yeah. So that was my point as well. Can I make a comment?
Yeah.
So that was my point as well, that you presented like as if it was a grand round. So as a teacher, you should be scaring the students, saying this is a very important topic, not only for the exam, but you should not be missing out. That's the message you want to send to your student, that you don't take it lightly. You see a cell reaction always. So that's how probably you should start. You did a great job, but from 7 to 8, if you have to go to 8, that's the message you send.
That is the transformation from a student to a teacher. Yes, sir.
Okay, can we have the marks now?
Yeah,
Can we
just,
have
a,
the
just a
marks?
comment, please. I think, Prachi, you began very well, actually. But I think where went wrong was that you did, I'm not looking at the scientific content or what you said, I'm looking at the way you said it, you know. I think your effort to connect with the audience was limited. You were mostly talking to the laptop or to the mic or to the screen, but you were not having any eye contact or any, you know, pinpoint, you know, some focus or attention in the audience. So as a teacher, I think you should connect with the audience more often, right? So that's where you make your point across.
Yes, sir. Great
Thank
input.
you.
I think everybody should take this. Can we have the judges show of marks? 7, Dr. Rashmin. 6, Dr. Bishwas. 5, Dr. Titiar. 5, Dr. Anil. Here, show it to us. 6. You have noted, Nilima? Please note it immediately. Okay. So just a word. This is also a event where the students learn how to teach. So a great input that you connect. There's an eye contact, and you come off the stage, come off the screen, and you have to swarm over the people and just try to, you know, impress upon them. Thank you, sir. And
Okay, so we have 31 marks for Prachi. Now over
31.
to the Bihar team.
Okay, now we have the next team which is coming up, Karnataka. With the mentor, they're going to have an intro, and then the talk will be given by one of the contenders. Karnataka.
Hello, the mentors, the mentees, the team, and the lead, judges over here. आपने बिहार में हर रास्ते पे तो देखा होगा, बच्चे बचाओ, देश बढ़ाओ. So we team Karnataka, we are here to save the child with a mission. And I have with me my 2 wonder women, Dr. Tasmia, who would be speaking on evaluation of the blind infant, and Dr. Ashwita, who would be talking on recent advances in the retinoblastoma. So my mentees, over with the mission. Let's save the child. Over to you.
Wow, what an intro.
So Dr. Deepthi Joshi from Karnataka introducing her mentees. Now we have Dr. Tasmia going first for Karnataka.
Hello.
Start speaking, no problem. Presentation? Yeah, you can just forward, just check them. Okay.
Okay, let's have the time begin.
Hello. Am I audible? Yes. Warm greetings, everyone. One fine day, an anxious couple presented to my OPD, telling that their close
Restart the timer again.
Hello. Hello. Hello.
Yeah, start.
Warm greetings, everyone. One fine day, an anxious couple presented to my OPD telling that their 5-month-old infant cannot see colorful toys or familiar faces. When I compared this with an apparently normal child, it got me wondering as to what the causes of blindness in an infant could be. These can be categorized into pregeniculate lesions such as Leber's congenital amaurosis and retrogeniculate lesions such as cortical visual insufficiency and delayed visual maturation. Now all these lack conspicuous signs, so the test that we do should be simple, easier to translate to the parents, and should help in our planning and rehabilitation. The examination begins by making the child sit comfortably on the mother's lap and a meticulous history regarding the antenatal birth complications, family history of congenital blindness, and the visual behavior of the child, such as its response to colorful toys, to familiar faces, to moving objects, to lights on and off, its own reflection in the mirror, any abnormal gaze, any abnormal head posture. Fixation can be assessed by introducing a colorful toy within the child's visual field and see if the child can fix and follow. The same has to be checked monocularly because children resist occlusion of the eye with better vision. Visual acuity can be assessed using preferential looking tests or these puppet faces. The smaller the face that can be identified, the better the vision. The same can be used for checking visual fields. Dynamic refraction aims at correcting any hyperopias or hypoaccommodation to enhance any residual vision. Optokinetic nystagmus induced by a rotating drum is a function of the visual function. Now, cortically blind infants show no response to this. The nystagmus induced in the direction opposite of the head turn of the infant recovers very quickly, whereas if there is a visual loss, it recovers very slowly and indicates a poor fixation. Certain clues we need to pick up. If there is nystagmus with a sluggish reactive pupil and roving eye movements, it's indicative of a retinal dystrophy with a very poor fixation. Whereas in CVI and DVM, pupil is reactive, there is no nystagmus. Ocular distal reflexive frangicetti is where the child tends to rub or press the eye in order to stimulate the visual cortex, seen in LCA. CVI infants tend to gaze towards light or objects of a certain color. Presence of diffuse arteriolar narrowing on fundoscopy is indicative of a retinal dystrophy, and this sign is termed as a poor man's electroretinogram. VEP assesses the visual system beyond the retinal ganglion cells. Now, cortically visual insufficient infants, if they have any response, it could indicate a better prognosis. But in retinal dystrophies, there's no response. ERG cannot be done until the age of 1 year because rods and cones take a year to mature, and if done before, the waves can be poorly defined. Neuroimaging is of paramount importance because it helps us to know the cause for CVI, be it meningitis, intracerebral hemorrhage, or hypoxic insight. So in brief, LCA infants have blindness at birth, nystagmus, and sluggish reactive pupils, a wide range of fundus pictures, and it's an autosomal recessive disorder. Cortical visual insufficiency infants have congenital horizontal gaze palsy, ipsiversive head turn, mildly atrophic disc. Now when all these tests are normal and still the child has low vision, it's followed up. Despite other abnormalities, they tend to regain their vision in DVM. So remember that happiness can be found even in the darkest of times if one remembers to turn on the light. The ray of hope for these infants is a combined effort between us and the teachers of visually impaired so as to rehabilitate them using whatever vision is left, using touch perception, colored objects, low visual aids, audiovisual aids, braille literacy, genetic counseling, because the only thing worse than being blind is having sight but no vision, as quoted by Helen Keller. Thank you.
Wonderful talk.
Call the Jharkhand team.
Yeah, so can the Jharkhand team and mentors please come on stage on the other side, please? Yeah. Wonderful talk, wonderful use of all the paraphernalia. Over to the judges.
Ma'am, I had attended Dr. Deepthi ma'am's class, and Dr. Deepthi ma'am had told me that you should do MRI in all patients, ma'am. What is your opinion, ma'am?
No.
I'm not, sir. I'm a student.
Yes. MRI is required to know the cause for the CVI. So this depends on what history we're taking. So if there's a significant history of low birth weight, any history of baby not crying immediately after birth, NICU admissions, it's always better so that we can know any hypoxic insult if that has happened. Now we also need to be careful of one thing, that is battered baby syndrome. So these infants also can have some intracerebral hemorrhage, and that may pick up on an MRI, any skull fractures or any intracerebral hemorrhages. So that is also one entity we need to be careful. So depending on the history and depending on the examination, I would actually go ahead with an MRI.
Ma'am, I've been just asked one question. One, set induction was beautiful. That's it for the mentor. For you as the teacher, I'm a student, so I'm going to ask you, ma'am, how is Cardiff charts different from Taylor's charts, ma'am? And what is, for these low vision child, if you can't correct, what is the way forward in schooling as per Government of India recommendation?
So Cardiff charts is better for a child who has a better vision, which is why we are using preferential looking tests. All these tests have gradings of different intensity. So even a child with a little low vision can sort of pick up whether the lines are there and where they are present, or depending on the faces. So these preferential looking tests are way better, because in CVI or in pre-verbal infants with a poor vision, they tend to pick up these charts better, which is why we are not using a Snellen's chart or any other chart. And human children tend to gaze at faces which look like humans, which are of the same species as them, which is why we're using these puppet faces which look like a human. So even with, we need to remember that CVI infants. I'm not sure. I will. Okay.
Okay, so can we
Yes.
have the
Can we have the
judges'
marks?
scores? Yeah.
8, Dr. Rashmin Gandhi.
8.
Please note.
And
7, Dr.
7.
Anil. 8, Dr. Titial. 7, Dr. 8. 8, 8, 8, 7, 7. Thank you, Dr.
8s.
Tasmia. Now we have the Jharkhand team. The mentor is going to introduce his mentees and we're going to start.
Hello, good morning everyone. Johar. We are from the Jharkhand, and with me we have the two very smart, intelligent, and definitely they are going to be teachers of tomorrow. One is Dr. Abhishek and another is the Dr. Subham Hars. So thank you everyone and good luck to my team.
Thank you, sir. Can we have the candidate?
So who is the first person presenting?
Yeah. Yes. Dr. Abhishek Sinha will be presenting.
The most exciting thing I have missed. And the most exciting things are why we are all here is also to win, to teach and to win. So the winning team in the first position is going to get 50,000 rupees.
So you didn't tell this before.
Not to judges also, you should have told them.
The team in second position is going to get 30,000 rupees. And the winning team in the third position gets 15,000 rupees. The
Now you have to
judges
take more interest.
are judges beyond financial.
It is between the students and the judges after the event.
Or before the event,
Love,
already.
affection and respect for the judges.
And the best teacher for tomorrow gets 30,000 rupees. The best teacher for tomorrow in the second place gets 15,000 rupees. And the best teacher of tomorrow in the third place gets 10,000 rupees.
That is additional to the team.
Yes.
Oh, boss, you have a double whammy. You can be in the best team, you can be the best mentee, you can be the best taught, and you get both. So judges, things become more now interesting. Yeah, over to you, Dr. Abhishek.
Am I audible? Hello.
No, you have to check, you don't.
Good morning, everyone. My topic for today's presentation is approach to contracted socket. So, contracted socket is the shrinkage or shortening of all or part of orbital tissue, causing a decrease in depth of the fornices and orbital volume, ultimately leading to an inability to retain prosthesis. There is characteristic loss of conjunctival surface area, deep cicatrix formation, atrophy of the orbital fat, fornix contraction, and volume redistribution. There may be a history of prior surgery, and patient complains of poor cosmetic appearance, and sometimes the patient may also be a child with a history of underdeveloped socket. So, in the examination part, rule out any kind of metastasis which was carried out to room intraocular malignancy such as retinoblastoma. Do a general ocular examination such as eyelid, look for notches, abnormalities, lid closure, lash position, laxity, lid margin, etc. Assessment of the socket, compare the general appearance and symmetry with the other side of the patient. A dry fibrotic conjunctiva indicates a poorly vascularized socket. Socket area, you just insert a blunt lacrimal probe into each fornix and note down its length. Most importantly, the inferior fornix as it supports the prosthesis. Socket volume, you can compare the socket volume with the fellow eye and look for muscle movements tone of the orbicularis and tarsal to rule out any kind of inflammation. So this is the anatomical change which occurs after evisceration. There is a reduction in the volume, and we can see the inferior fornix, the depth has significantly, it has become very narrow. So investigations, in short, it's microbiological investigation to rule out any infection, and radiological investigation in case to rule out any fracture in the orbit or a buried implant. So grading by Gopal Krishna classification grades it into five grades. First is the healthy conjunctiva and well deformed fornices. Grade 1 is shelving of the lower fornix preventing the retention of artificial eye. Grade 2 is loss of upper and lower fornix. Grade 3 is the loss of upper, lower, medial and lateral fornix. Grade 4 is grade 3 plus reduction of palpebral aperture in the horizontal and vertical dimension. And grade 5 is recurrence of contraction after repeated trial of reconstruction. So these are the images depicting the different grades of the contracted socket. Treatment primary aim is to create socket and maintain prosthesis, giving a good cosmetic appearance ultimately. So in case of mild contracted socket, just deepen the inferior fornix. In case of moderate contracted socket, a healthy vascularized socket is there. So mucosa, split skin or dermis fat graft could be used. In case of severe contracted socket, it would require both area and volume replacement. Thus, a composite graft with autologous dermis could be used, like autologous dermis fat graft. The fat would provide the volume and dermis would provide surface area, and pedicle flap, if used, will increase the chance of survival. So moist socket, in case of moist socket, you can go for amniotic membrane or full thickness buccal mucosa graft. In case of dry socket, you can go for split thickness skin graft, followed by permanent prosthesis after 4 months. In case of recalcitrant cases, you can go for spectacle prosthesis, smoke lenses, plus minus lenses to magnify a micro-ophthalmic or minimize a ophthalmic socket. This is an example of grade 1 contracted socket managed by fornix steepening suture. So prevention is better than cure. Proper dissection at the time of initial procedure itself should be done. Preserve as much conjunctiva and tenons as possible during the initial procedure. Avoid oversized prosthesis, and radiotherapy, if required in case of patient, start with a fractionation dose. That would be all. Thank you.
Oh, thank you, Dr. Abhishek. That was a very well presented talk. Over to the judges for any questions. Yeah, Dr. Anil.
अभिषेक सर, ये बॉडी कंट्रैक्चर क्या होता है? I don't understand that term.
Sir, it's just the contraction of the, sir, it's not bony contraction actually, it's the contraction of the socket area, sir. The socket volume just decreases and looks as if the eye is just pushed inwards. So.
Okay.
Any questions? Any other questions from the mic, from the judges?
Okay, again, as a teacher, you have to... Sir, actually, you will be happy I am asking questions which none of you want to ask. So it's a very difficult topic which you covered. But again, the same thing comes again and again, and this is basically a very camaraderie which we're talking about you. Be specific on what you want to talk about. That was the suggestion. As a this thing, if you could have, do you have any video on that? That will have added much more value to it. Your topic of 4 minutes, if you could have just, because your topic is approach to a contracted socket. So do you have any video which you have seen, and what difficulties do you face in doing this surgery?
Ma'am, right now here I don't have any video to
Okay, so all right. Sir, I want to ask one question. In a reconstruction of a contracted socket, sir, what antimitotic medicines are used?
Sir,
and what are their concentration? How long we use in the different surgeries?
Sir, in case of reconstruction in contracted socket, we generally, sir, in case of reconstruction, we admit the patient in our side. We admit the patient and we use after pre-operatively we use antibiotic a day earlier, and then
antimitotic.
Yes,
antimitotic drugs. When it is used in a contracted socket
Pardon, sir, I
reconstruction?
am unable to. Antimitotic drugs, yes, sir. Okay. Okay.
Okay, thank you, sir.
Sir, it is
Thank you,
my
thank you, sir. Thank you,
Okay.
thank you. Thank you.
Students, we are getting late. Okay, thank you, Dr. Abhishek. Now it's the time to receive the team West Bengal. Can we have the judges' marks, please? 5, 5, 6, 6.
10. Give me 10 seconds. 6, 6, 6.
6. 5, 5, 6, 6, 6. So team West Bengal now.
Yeah, good morning. I am Dr. Sugatopal. I am mentoring my team, Dr. Himani Chatterjee and Dr. Ashish Majumdar. In cold Bihar, we have been welcomed with very warm heart, and our history is being created. Firstly, the first AIOS midterm, and secondly, the first teachers for training for tomorrow. Yeah. So I have asked them to enjoy the stage. It's not about the competition. It's about enjoying the stage, because I'm sure these two very bright students will be a great teachers for tomorrow, and their students will make India pride in future. So the stage is yours.
Thank you, sir. That was a great introduction. Over to Dr. Himani. The next team, Telangana, be present there and be ready with your thing.
Himani Chatterjee, wound construction.
Hello. Am I audible?
Mike.
Hello. Am I audible?
Yes, ma'am, you are audible.
So, very good morning to all my students. I am Dr. Himani, and today we are going to learn about proper wound construction and how to minimize astigmatism post-cataract surgery. You don't want your patient to look at a picture of a beautiful lady and see this, do you, after cataract surgery? Because cataract surgery has now become synonymous with refractive surgery. Patients expect the best uncorrected visual acuity on the first day itself. So, mind your incision, because that is the main portal for lens nucleus delivery and IOL implantation. If not fashioned properly, it will induce astigmatism, and at the same time, it also has to be self-sealing so as to reduce post-operative endophthalmitis. Now, for a proper wound construction, remember the mnemonics SIDS, that is site, size, shape, internal incision, distance from the center of cornea, and the side port. We'll be looking at each aspect one by one. Let us look at manual small incision cataract surgery. Students, first comes the site. We can give the incision at superior, superatemporal, or temporal depending on the steeper axis. Now, it is seen that the amount of astigmatism is directly proportional to the length of the incision and is inversely proportional to the distance from the center of cornea. Next aspect is the size. For a self-sealing property of the wound, the incision should follow a square incisional geometry where the length of the incision AB should be equal to or more than the depth of the incision BC. But always remember, plan your incision prior to the surgery depending on the grade of the cataract. Coming to the shape of the nucleus of the incision, there's a concept of incisional funnel, which is an area between two paired curved lines separated by 3 mm at the limbus. So any incision made at this area is astigmatically neutral. So the types of incision given are smile, straight, frown, Blumenthal, and chevron, with the chevron being the least astigmatic and the smile being the maximum astigmatic. Let us look at a video of a triplanar sclerocorneal tunnel where the surgeon gives an incision of 4.5 to 5 mm size. He makes a scleral incision, a scleral dissection with the crescent knife and the scleral pockets, and finally entering into the entry chamber with a keratome blade, which is parallel to the iris. Coming to phacoemulsification, the site is similar to what explained earlier. It can be superior, superotemporal, or temporal, depending on the steeper axis. And it is a bi- or triplanar structure made with a 2.2 to 3.2 keratome, fashioned in a triplanar way, with a depth of 1.5 to 2 mm size and a triplanar corneal incision parallel to the iris. Last but not the least, the side port incision, which is made with 15-degree angle blade at 8, 9 or 10 o'clock position from the main port. But studies have shown that side port made at 90 to 110 degrees from the main port is astigmatically neutral. So, to summarize, students, remember, mind your incision SIDS. Remember this mnemonic: size, site, shape, internal incision, distance from the cornea, and side port. Students, take a picture of this slide so that you can remember it by in the last minute. To take home message: a happy patient and satisfied patient is always equal to a happy doctor. So always give the opportunity to write to a beautiful site to the patient. If you have any doubts, clear it up with me personally. I'll be always available for you. Thank you.
Thank you, teacher. टीचर हमने बहुत ऐसा स्लाइड हमने फोटो लिए मगर पूरा मेमोरी खत्म हो गया. We end up deleting it in the end finally. So that was a great talk. Judges.
Good morning, madam. It was a very nice class on how to do incision. I have few queries. One, for a toric implantation in a phaco-emulsifying surgery, what should be the site of incision? And how does it make a difference? Especially for a toric IOL implantations.
So yes, you are a very good student. Just
Thank
like you are my very good student. Can you answer this
4 साल से
for
इसी
me?
क्लास में है इसलिए.
Can you answer this, ma'am? You are a very good student of mine.
Let me.
वो 4 साल से इसी क्लास में बैठे इसीलिए.
Ma'am, that's.
I have high hopes from you.
That is good. That is amazing reply. Okay. But don't make it a habit, okay? Don't make it a habit.
आपको, you are getting salary to teach, madam.
Second question on the same thing is, we do see in India, in the OPDs also, we see a lot of patients coming with the radial keratotomy incisions. Sometimes there are more than 32 incisions. Suppose we have to do, ma'am, phaco surgery, how should we plan a main incision or a side port incision in these patients? And what complication can occur in these cases?
So this question is beyond the scope of this class.
Okay.
I'll surely read it up and clarify your doubt next time, sir.
One of the major, apart from the induced astigmatism, ma'am, people say incision, can cause the descending membrane detachment. So which type of instrumentation would cause more descending membrane detachment in the wound site?
Pardon, can you repeat the question, please?
Okay, thank you, ma'am. We'll read at home and next day we'll tell you
ने
everything.
सबको पानी पिला दिया. I just gave the bottle of water. Everybody is drinking. Judges, 8 Dr. Rashmin Gandhi, 8 Dr. Kirti, 10 Dr. Bishwas. 10, very good. 8
First 10.
and
First
7.
10.
Okay. So now we have the mentor, Dr. Harshul Turk, to tell us about what is life within ophthalmology.
So good morning, everybody. I present to you Team Rajasthan. Can I have my feed? Volume, please. So presenting to you teachers of tomorrow, Dr. Sunena Patila from Bikaner, Rajasthan, and Dr. Ishita Agrawal from Jaipur. Khammagani, they say, welcome you all. So over to you, Dr. Ishita.
So now it's Team Rajasthan, Dr. Ishita. Can we just reset the timer, please? And the next team from Orissa, be please ready on the other side. Okay, when they are presenting, you be ready so that, and you also decide who is the first speaker.
Good morning.
1 second, Ishita, 1 second. Start.
Yeah.
Good morning. My topic for today is oculofacial aesthetic procedures. Aging gracefully is one thing, but trying to slow it down is another, and oculoplasty is taking momentum in doing the same. Let's see a quick anatomy. The lid creases is formed by the superficial insertion of the levator aponeurosis and the lower lid retractors. It is approx 10 mm in males and 8 mm in females. There are two main fat pads, upper and lower. The lower are further divided into medial, inferior and lateral. This image depicts the danger zones, the arterial danger zones, which should be kept in mind during the injecting fillers. There are 3 aging Ds, 3 Ds of aging, that is deflation, that is the loss of facial volume. We can see that hollowing of the cheek and under eye area. The descent is the sagging of the facial tissues, that is drooping of the eyebrows and the angle of the mouth. Deterioration is this texture and the color changes of the skin. Upper lid assessment should be done properly, like we can see dermatochlosis, upper eyelid fold, as in the picture, or they can be overhanging of the lateral eyelid skin, lateral hooding. Pseudodermatochlosis, brotosis should be differentiated. In lower lid assessment, hills and valleys should be properly assessed. Hills can be protruding orbital fat or fluid-filled malar bags of fistunes. Valleys are the tear trough deformity in the lower lid. Eyelid laxicity and redundant skin, hypertrophied orbicularis muscle can also be seen. The fat and fluid should be differentiated. The fat prolapse will be compartmentalized. It will be limited to the inferior orbital rim and becomes more prominent in upgaze, whereas in the fluids, it will be within the skin, not restricted by the orbital margin and non-compartmentalized. The 3 aims of facial rejuvenation is revoluminization, which will be achieved by the injectable fillers and fats, repositioning, which is the surgical treatment, aim at reversing the descent, that is the brow lift, blepharoplasty, mid-face lift, resurfacing the skin, that is undoing the deterioration of the color and texture. Revoluminization can be achieved with fillers, that is hyaluronic acid fillers or autologous fat fillers for brow lift or tear trough deformity. Botox is a non-surgical, is done for non-surgical lift and volumization. It is used to treat wrinkles that can be glabular lines, horizontal forehead lines, crow's feet, or facial contouring, brow lift, and orbicularis roll. Repositioning procedures can be done medically with Botox, or lower lid blepharoplasty can be done that to tackle the fat pads or tackling the mid-face. In tackling the fat pads, excision can be done in younger patients through transcutaneous or transconjunctival or relocation in the older patients. These are the few blepharoplasty steps. First, we make the incision and then excise the excess skin and the fat is prolapsed. After that, the lid crease is made with 6-0 Vicryl and lid closure is done. Resurfacing is a non-surgical technique done to alter the problems of skin texture and color, derma ablation, chemical peeling, laser surfacing. In newer modalities, we have anti-glaucoma drug bimatoprost used to treat the eyelash hypotrichosis to lengthen and change the thickness and color. To conclude, I would like to say wrinkles will go where the smiles have been, and it's always the patient's choice. Thank you.
Oh, great. Actually, what happened is your children whom you are teaching are all slightly older, so they were looking keenly into your presentation. So I am sure that they will have a lot of questions to ask. Over to you, sir. Personal question. Yeah.
Gopal, you're mistaken. We are very, very young people, you know. We are the real students.
We are all Botox.
No, ma'am, I've seen some eye doctors doing hair transplant. Can you, do you recommend that? Would that be?
Not part of it.
Bal bach gaye bas.
Do you think that's part of our armamentarium?
Sir, that's beyond our aura, our scope. We would just recommend the forehead and the periocular area, and also we can go up till the mid-face. Periocular area is also not something we would like to do. That will be, yes.
Out of the border.
So let's have the marks. A 5 and a 6 and a 6 and a 5 and a 7. Okay.
I think with this, all the postgraduate students can take some point, like how to become a good speaker. I think they will also critically comment on the other things. For example, if you have a too busy slide, actually the audience will be really, confused about whether they have to listen to your talk or look into the slide. Use the custom animation in the PowerPoint. You have custom, you can just, only what you're talking can appear on the screen. instead of the entire thing, because we are reading from the top and they are reading from the bottom. So you meet nowhere. So use those features in PowerPoint so that it can be more effective. Okay, now we have the team Orissa, Dr. Aishwarya Das. Madam, you can introduce your team.
Good morning, everyone.
People here because they volunteered for an adventure.
Exactly, yeah.
I mean, 10 to all the mentors and 10 to all the students.
Yes,
Actually.
you have 10 marks from each judges actually already in your kitty. This is just for the competition, okay? So that's a great remark.
Good morning, everyone. I'm Dr. Devi Aishwarya Das. I have with me two bright students who are building up to become the best teachers for tomorrow. One is Dr. Jenixon from AIMS Bhubaneswar and one is Dr. Ayantika from JPM Rotary Cuttack.
Can you on the video, please, and the audio?
Audio, please, Iska.
So the team Orissa, we were asked to name our team as per an eminent ophthalmologist. So I've chosen the grandest teacher of India that India has, Dr. S.S. Badrinath. So a good teacher knows that I do not know all, and a good teacher learns from the students. So I hope the teachers here will learn from the students there. So Orissa, as always, has a rich heritage. So every tomorrow is built from the laps of yesterday. So this was about the intro video. I think we can get on with the class. Thank you.
Yeah, great intro, Dr. Devi Aishwarya. Rene do. Okay. So the next team, what is the next team? No, in the order.
Who is the next team?
Okay. We'll tell.
Hello. Assam, you can go there. Assam, Kasturi ma'am.
Assam to be ready on the other side.
You can start.
Well. Good morning, everyone. So, let's go and wriggle into the topic of today, that is ocular cysticercosis. So, what is this cysticercosis? Cysticercosis is primarily a parasitic infestation caused by Cysticercus cellulose, that is the larval form of Taenia solium, also known as the pork tapeworm. So, this adult tapeworm is harbored in the human intestine, which makes us the definitive host. Wait a minute, students, do you think that why are we discussing this in our class? Why cysticercosis? Because the World Health Organization survey says that cysticercosis is endemic in a lot of developing countries, which includes, guess what, India also. And among all the cases in India, 12.8% of the cases has ocular involvement. Well, that makes us discuss about this topic. So ocular cysticercosis is the most common parasitic infestation of the eye, which has its own variants. That is the intraocular involvement, which is more common in the Western world, and the extraocular involvement, which is more common among the Asian population. I guess you get it. And the most frequent and severe manifestation of ocular cysticercosis involvement is of the posterior segment. So how do we get it? Accidentally. If there is ingestion of the embryonated eggs by the human host, then we might develop cysticercosis in the subcutaneous tissue, skin, or in the brain, or in the eyes. So, the presentation wise, the intraocular cysticercosis has an anterior chamber cyst that presents with pain, redness, and diminution of vision. And it is believed that the path that was taken by the parasite was through the angle structures or through the choroidal vasculature. And in an intravitreal or an subretinal cyst, it is believed that it has taken the path of the high flow choroidal vasculature. So coming on to the extraocular variant, the extraocular muscles involvement is more, and it is believed that there is a hematogenous spread and that can present with an orbital swelling or extraocular muscle restriction. and whatnot. This extraocular cysticercosis can also involve the orbits. It can involve the optic nerve, it can involve the eyelid, it can involve the lacrimal gland and the lacrimal sac area. So, investigations basically will augment your diagnosis of an intraocular cysticercosis, and it can confirm the diagnosis of an extraocular cysticercosis. Considering blood investigation, it must be remembered that students remember ELISA can only augment the diagnosis, but a negative ELISA will not rule out the infection. So how do we manage this? Conservatively, we can use albendazole orally, 15 milligram per kg per day, or we can use, along with that, we can use steroids, that is prednisolone, 1 mg per kg per day for a period of 6 weeks, that is, and the patient is followed up every 2 weeks. Alternatively, praziquantel can also be given. Surgical management for an intravitreal cyst can be done using a high cut rate vitrectomy cutter, and for a subretinal cyst, you can use a retinotomy near to that, so to prevent any damage to the retinal vessels. So, students, remember, this cysticercosis is definitely preventable by proper sanitation and creating a public awareness. That should be our long-term goal. Understood, right? And having this one, like uncooked meat and uncleaned raw vegetables, should be prophylactically avoided to prevent this disease. Thank you for your patient listening. Thank you.
Wow. Teacher बहुत कड़क है. Beware.
Sir, one of my seniors was asked in the Viva.
Yes, Bacha.
Disc edema and cysticercosis. So how do we answer that question?
Cysticercosis, disc edema. You have seen that?
No.
Which year you are in? Which year you are in?
I'm in second year, sir.
You are in
third
second
year was asked. Yes,
okay,
sir.
third year has seen that.
No, he was asked.
He
was asked by Dr. Tityal from AIMS.
Okay,
He came as an
okay.
examiner. He asked that where would you see disc edema in a system?
See, do you know when a teacher is really happy and impressed?
Mhm.
A teacher is really happy and impressed when the students are very attentive to the class, and when the student asks such a question that even the teacher can't answer. That is when the teacher is very impressed about the class. Definitely, I will answer the question to you and also to your senior by referring to Dr. Tityal. Don't worry.
How it looks under microscope if you make a section of cysticercosis? How it will look under microscope?
Well, that is in the scope of my pathology department, actually. But I think you can see the scolex inside in the cyst that will be present.
Sir,
Cyst with a scolex will be seen inside.
see the hooklets also.
Yes, absolutely. You have learned your second year microbiology very well.
Sir, is it correct? Suppose we have to start a medical treatment in these patients.
Yes.
We should be doing a CNS CT scan to rule out CNS cysticercosis, sir?
Yeah, obviously, if there is any associated presentation, if the patient is presenting with any symptoms, because...
So is it compulsory to do a CT scan for these patients before starting the medical treatment, sir?
we can do it. We can do it for sure.
No, we should be doing, sir, not can.
We can do it. Yeah.
Okay, now the marks.
Thank you.
Please, 8 and a 9 and a 10.
Wow.
And an 8.
And an 8.
And a 7.
Sir, you have to ask about disc edema and because you asked in
in Viva. In Viva, he has asked his senior.
So, you forgot the answer, sir. Okay. So now we have the team Orissa here.
No, Assam.
Oh, it's okay. Team Assam. So that was team Orissa. That was fantastic. Now you have team Assam. Okay.
Awesome, Assam.
So, are you all enjoying? That's the first thing. Raise your hands if you're enjoying. Give a big clap to the teachers of tomorrow. Inspire them.
Yes, Dr. Kasturi.
Very good morning to all of you. Myself, Dr. Kasturi Bhattacharjee.
I am from Assam. Assam is the gateway to the Northeast India, having 7 states, and now Sikkim has joined us. So today, me, Dr. Kasturi, along with my 2 mentees, the first year, Dr. Ritusha, she is a DNB first year mentee, and Dr. Jinia, also a DNB resident, who will be representing not only Assam, the whole of the Northeast. So while introducing, while teaching my mentees, what I have learned from my professor always used to say that whatever you have learned, you give it back to the community. So whatever little or whatever maximum I have learned from the professors, that is what I taught my mentee, with a request and with the understanding that whatever they have learned from me, and they'll give back to their next generation and give back to the community. So with this, I introduce both my mentees. Ritusha, she is a first year DNB. She'll be a teacher for you today. I'm sure she'll teach you very well. And secondly, another of my DNB resident, Dr. Jinia. Thank you all very much.
Thank you, Dr. Kasturi. And Ritusha, over to you. Are you going to present first?
Yes, sir.
Yeah. First year resident. Good.
Good morning, dear students. Am I audible to you all? Yes, sir, sure. Today, I would like to make you all look into the future of the cataract surgery, which is femtosecond laser assisted cataract surgery. First of all, coming to why do we need femtosecond laser cataract surgery? It has a predictable and safer results. It replaces the technically most challenging steps of the cataract procedure and is easily reproducible by all the surgeons on the board. Femtosecond laser is basically an infrared radiation laser with a wavelength of the power 10 raised to minus 15. It has a photodisruptive effect on the target tissue. That is, it converts the solid state of the tissue into a plasma state. In the plasma state, there are free electrons and ionized molecules which allow the tissue particles to rapidly expand and collapse, creating microcavitation bubbles. These bubbles will create acoustic shock waves which will separate and incise the tissue and leading to the femtosecond laser effect. The FLAX system basically has 3 components: the computer-guided system, the OCT imaging system, and the femtosecond laser. It allows us to counteract the 4 most important steps, 3 of the cataract surgery and 1 to counter the astigmatism. First is the clear corneal incision. Second is a well-centered and a predictable capsulotomy. The fourth is a nucleotomy. The third is the nucleotomy, and the fourth is an arcuate incision to counteract astigmatism. There are a few challenging cases with the conventional cataract surgery which are overcome by the FLAX technology. Coming to the first case of the posterior polar cataract. One of the most challenging things about the posterior polar cataract is to protect the posterior capsule and avoid the posterior capsular rent. How FLAX helps us with this, it creates an epinuclear plate or an epinuclear cushion and divides the nucleus into small cylindrical segments, which allows us to protect the posterior capsule as we are going through the phacoemulsification procedure in the PPC. The second case is of the hard cataract. As we know that we have all encountered this, that in a hard cataract case, we use a lot of phacoenergy to emulsify the nucleus. And this will result in endothelial damage, leading to the next day of corneal edema. To counteract this, we are already dividing the nucleus into smaller fragments with the help of this FLAX laser. And this will allow us to use lesser phacoemulsification energy and allow us to have a clearer cornea on the next day post-operatively. Coming to white cataract, I'm pretty sure with manual capsulorhexis, most of us at least some point in our life have experienced the Argentinian flag sign. Quite dreaded. I am sure a lot of us agree with this. How FLAX helps us with this, it gives us a predictable, a well-centered, and a nicely located capsulorhexis, thus avoiding the complication of the Argentinian flag sign here. Here we have an image, a video of the arcuate incisions. Arcuate incision is to counteract the astigmatism of a power of less than 1.5 diopters. FLAX system helps us to achieve the precise depth and location of these arcuate incisions. Subluxated lens is also a challenging case to do a manual capsulorhexis in, which the FLAX system helps us to counteract. We have already discussed with all these videos, very beautifully done videos, of what are the advantages of the FLAX system. Here is a very interesting image of the river Dwaki located in Shillong, Meghalaya. It is very well known for the clarity of its waters. And we need to realize that the patient, when he comes with cataract and opts for a cataract surgery, he expects a similar clarity in vision. And we as surgeons need to provide the same. I want to stress on one important thing here, that in spite of the flax being a machine-dependent procedure, the surgical expertise and the surgical judgment of the surgeon is irreplaceable. We are just complementing, the flax system is just complementing the surgeon's surgical expertise. And as we evolve from the process of ECC to SICS to Phaco and now to flax system, I think we are moving towards precision, and we should welcome the flax system with open arms. Thank you.
Okay, thank you, Rutusha.
Thank you, sir.
Good presentation. They were looking for a teaching. Yeah.
Ma'am, as you ended with, SICS, can this femtosecond laser be assistant to SICS also, ma'am? If yes, how?
Yes, sir. We can, the few steps of SICS can be very well done with flax, very predictably done with flax. And the rest of the surgery can be further ahead done with taking the patient into the OT with the SICS procedure, sir.
Ma'am, we know that, there's something called interface in these, femtosecond laser devices. So what are different types of interfaces being used for these femtosecond lasers for a cataract surgery, ma'am?
Sir, I'm aware, I'm not sure if it is the interface that is there, but Lensex is one company that is...
Without interface, laser cannot be delivered, no?
Yes, sir. Sir, I will read up on that and let you know, and see you in the next class for that.
Okay, ma'am. Fluid interface, contact interface.
Yes, sir.
Okay, well done, Dr. Rutusha Dodwad. So,
thank you.
We have the marks. 6, Dr. Bishwas, 7, Dr. Gandhi, 7, Dr. Anil, 6 and 6, Dr. Titiyal and Kirti. Okay, now the team Kerala. I think the team Kerala was responsible for actually having this event. When Dr. Partha actually was attending the Teachers of Tomorrow in Calicut, so that inspired him, and that's why we are all here. So welcome team Kerala, Dr. Srini, the mentor, and his 2 bright mentees.
Video.
It's not playing.
It's thoda audio.
No.
Good morning, everyone. It's my pride, privilege, and honor to be the mentor of these 2 brilliant kids from Kerala, Dr. Alan and Dr. Lisa. As students, you will have a real class by real teachers.
You are
Enjoy the class.
वो धमकी दे रहा है.
Mentors धमकी दे सकता है.
He's threatening the students. You have real class.
श्रीनी, AI पढ़ा रहे हो तो टीचर्स भी simulated होने चाहिए.
Check your audio before you start, because it's little trouble. Hello, bolo.
Hello. Hello.
बच्चे सो गए.
Which one? Good morning. Today we'll have a small class regarding the topic ROP screening. And to talk about this today, I'll use the help of the 5 W's and 1 H of what, when, where, whom, why, and how, apply it to the context of ROP screening and see what we can learn from it. So what is this ROP that we are so interested to screen for? It is nothing but a disease affecting the retinal blood vessels of a preterm baby. Normally, the retinal vascularization is a very well orchestrated process starting at 16 weeks and terminating at 9 to 10 months. But in a preterm baby, this process gets hampered. Initially, the baby is put under supplemental oxygen. There is a gush of oxygen reaching the retina, and the retina stops the production of normal blood vessels. The baby is taken off oxygen. The parents are happy, but not the retina, which now feels cheated of the excess oxygen it initially received and now responds by producing abnormal blood vessels, which we term as ROP. Now, why do you want to screen for this disease? This is simply understood by the fact that ROP is not a single shot disease. It doesn't just come and go. It comes, hits you hard, and leaves its traces for a long duration of time. And this is explained by the stages. It begins with the demarcation line separating the vascular and the avascular retina. The line becomes a ridge. Along the ridge, you've got now abnormal blood vessels sprouting out. And later on, these will begin to pull onto the retina, causing tractional retinal detachments, which would be initially partial, may or may not involve the fovea, and finally leave behind a totally detached retina. Now, does every preterm baby have to be screened for ROP? No. If your baby has got a birth weight of 1.5 kilogram or less, or a gestational age of 30 weeks or less, or an unstable clinical course, go ahead and screen for ROP. Now, when do you screen for ROP? Again, think about how ROP develops. It takes some time for the retina to feel cheated and show the changes of ROP. So the first examination is usually kept 4 to 6 weeks after birth, and keep repeating it on a 2-weekly basis till you have ensured that the retina is completely vascularized and free of ROP changes. Now, where do you do it? Maybe your baby could be unstable and you will have to do it out in the NICU, but in stable enough, you can even carry it out in your OPD. Now, how do you go about this process? You need the pupils to be dilated, for which you make use of your dilating drops, the lid speculum to keep your lids apart, your indirect ophthalmoscope with the condensing lens, your indenters to depress the sclera and get a view of the entire periphery, and finally, a drop of paracaine to just ease out the process for the baby. You examine the fundus, get a view of the posterior pole, and a complete view of the periphery and look for changes of ROP. Now, a recent advancement is the development of the RetCam. What it does is that it gives you real-time, wide-field view of the fundus, which makes it so much easier both for the ophthalmologist as well as for the baby. It helps you get a more accurate view of the fundus. You can store those images and even send it across to others if you're in doubt. Finally, whatever changes you see in ROP, they're always commented with respect to zones. For the purpose of ROP, the fundus is divided into 3 zones, 1, 2, and 3. 1 being formed keeping the optic disc to the center and taking twice the distance from the disc to the fovea as the radius. Zone 2, you keep the optic disc as the center, take the distance from the disc to the nasal aura as the radius and draw the circle. That becomes your zone 2, and whatever lies beyond this is your zone 3. So to finally conclude, I hope this short class has given you some direction regarding the what, when, where, whom, why, and how of ROP screening and help you bring a great difference in life of these precious ones. Thank you.
That was brilliant, Dr. Allen. Now for the judges, students. Can we have the mic?
What speculum you use it for ROP screening?
So we can use the Alfonso eye speculum.
Sir, a very nice class. How do you take about the way forward for preventing blindness due to ROP? You told us the who, why, where, what. What is the other collaborations you need to prevent blindness in ROP? What are the strategies for that?
Once it is already developed,
Blindness to
Strategies
prevent that.
to
The
reduce
ultimate aim is
blindness.
to reduce blindness in ROP babies. So, what are
the
the
first thing-
strategies for collaboration?
Overall, the first thing would be picking out ROP in the earlier stages itself. So your screening itself has to be proper.
How do you
And
know?
once-
How will the child come to you for screening? Whom do you have to sensitize?
Okay, that you'll have to go for the indications of whom to screen. Your preterm baby that's got a gestational age of 30 weeks or less, or a birth weight of 15.5 kilogram or less.
Collaboration with the pediatricians and with the parents. That strategies have to be there inbuilt.
Okay, then the
before that.
pediatrician could have some indications like maybe the baby had an episode of cyanosis, apnea, was under mechanical ventilation, septicemia. All those are indications of an unstable clinical course, which probably the pediatrician or the neonatologist will tell us, and we will have to definitely screen for ROP in such babies.
Yeah, well done. I think the scores now.
An 8.
8 from
And
Dr.
a
Gandhi,
10,
8.
and an
10 from-
8, and a 9,
and
and a 9. That
Well
makes an
done.
impressive score.
Now it's Team Telangana. Dr. Arvind Maurya, the mentor. Dr. Arvind Maurya with his two bright mentees.
Good morning all, and thank you so very much for giving us the opportunity, and it's an honor to be part of this program, this academic event of Teachers of Tomorrow. So I will present to you Dr. Shefali Chahar and Dr. Rolika Bansal. Over to you. Go girls and conquer and win.
Team Delhi to be on the other side.
A very good morning, everyone. Well, from Rajasthan, based in Bangalore, working in Hyderabad. So, Dil Se Pan India. My topic for today is ophthalmic manifestations of HIV infection. AIDS is acquired immune deficiency syndrome, and human immunodeficiency virus is a virus which is an RNA virus which causes AIDS. Any HIV infected individual with a CD4 T cell count of less than 200 has AIDS by definition, regardless of the presence of symptoms of opportunistic diseases. So what is happening in this disease? The virus actually infects the T cells, the T helper cells, macrophages, or the B cells, and it causes interference with the immune system that causes all the problems here. Any organ system in the body can get affected, and so can be the eyes. Hence, ophthalmic manifestations, the ocular lesions can occur in about 75% of the cases of AIDS. Dr. Biswas et al. Were the first people to actually document these ocular manifestation in AIDS disease people. And pole to pole, if you can see the table here, anything can get affected in the eye, and I'll be touching upon these topics very briefly because of the shortage of time. Non-infectious microangiopathy, it is a conjunctival vessel abnormality. HIV retinopathy, you can see cotton wool spots, retinal hemorrhages, microaneurysm, telangiectatic vessels. Important here is to do what? Like if you can see these two pictures, is it HIV or something else? So important is to differentiate diabetic retinopathy, malignant hypertensive retinopathy from these lesions in the retina. Opportunistic ocular infections include anterior segment like microsporidial keratoconjunctivitis, herpes zoster, molluscum. These are some of the pictures. Posterior segment, the most common retinitis is cytomegalovirus retinitis, which can be a fulminant form, or it can present as a frosted branch angiitis form, which is usually seen in neglected, untreated cases. Opportunistic ocular infections, which are a little uncommon, are these: pneumocystic choroiditis, fungal ocular syphilis, ocular tuberculosis. Also, I would like to point progressive outer retinal necrosis here, which is caused by varicella zoster virus, herpes simplex virus, CMV. The neoplasia that can be seen in HIV-infected people are Kaposi sarcoma, non-Hodgkin's lymphoma, conjunctival sarcoma. Neuroophthalmic manifestations are also common, like cranial nerve palsies, visual field defects. Also, on the optic disc, we can see papilledema, optic atrophy, retrobulbar optic neuritis, papillitis, or even it can cause cortical blindness. Also, the drugs used for the treatment can cause complications, as are listed here that you can see. So, in a nutshell, I would like to say all the ophthalmologists need to know about these ophthalmic manifestations because they can be the presenting features of the AIDS, and we can be the first point of contact diagnosing these people with the AIDS. And hope is in the form of heart because these patients live long and a good quality of life because of the heart therapy that is going on. Thank you so much for your patient listening.
Thank you for presenting a museum of findings in HIV retinopathy. Over to the judges.
Madam Teacher, I learned a lot. I relearned that ocular lesions in HIV infection. from you. Yes, it's a fantastic.
Thank you, sir.
Ma'am, it's a very, very nice presentation. I have a question for the judges, for the audience, and for you, ma'am. As an ophthalmologist, I'm exposed to ocular manifestation of HIV. All of them are not manifest. As a surgeon, I am debarred from getting an HIV test from all my patients in a government hospital. I don't know about private. What about my rights? We have HIV people rights. You're not supposed to ask them. It's a question for all the learned people. We need to reform this. One of my students asked me, what about my rights? I don't know when I'm exposed to HIV patient.
It's not for the student.
I know. It's just
Not further.
It's just
No, you can have actually
What
ask
do you
a
ask
question.
Since you talked about, would you like
They
to
are
say?
so impressed that they don't want to ask you a question. Dr.
Would you
Bishwas
want to
wants
answer? No, she wants to answer it. She wants to answer.
I think I can open it for debate with the other students. I think we can have like a very good interactive discussion in the class. I think I'll let
Actually,
it
I
be
think the
open for
answer
other
should have
students.
been, this is the august body called AIOS, and AIOS has to, the Madam Secretary is there, and AIOS has to do
Dr.
that
Namrata
much
will answer
work
this.
that government hospital doctors get the privilege of getting an HIV test before they do a surgery for every patient. Yeah. Thank you, madam. Thank you very much. Right on time.
Okay, we have the marks.
There is no need for doing these tests because you cannot discriminate these patients based on these positivity. You have to treat them as, you know, as every person coming to us for treatment, for a surgery, as positive. That means you have to take all precautions.
Precautions.
So you have to take universal precaution for everybody who is coming to us for an intervention. That's
Absolutely correct.
Please, marks. Marks, please.
8, Dr. Gandhi.
8 and
Dr.
an 8.
Bishwas.
And a 7 and a 6 and an 8.
Thank you so much.
Okay, well done, Team Telangana. Now it's time to go to the capital city, the state, Delhi. Dr. Pranita Sahai, the mentor with the 2 bright mentees.
Good morning. Good morning, everybody. Can we have the slides, please? So it's a great privilege for us to represent Team Delhi. And I have my mentors sitting as judges here. And today, me standing here as a mentor, it's a privilege. So here we are, Team Delhi. So all of us are, as ophthalmologists, are busy clinicians and surgeons, but definitely the passion to teach and the enthusiasm and motivation of the students to learn, we definitely fit in time for both teaching and learning. So here, me, Dr. Pranita Sahai as the mentor, and with my fellows, mentee Dr. Anuja Patil, who's a retina fellow at Center for Side Eye Hospital, and Dr. Rana Jamil, who's doing comprehensive ophthalmology fellowship at CFS, are here to represent Team Delhi. Thank you. And I'll pass on the mic to Dr. Anuja, who will make the first presentation. Thank you.
Do you have the team from Bihar?
No.
Yeah, be ready here. Yeah.
Should go. Okay. Start, sir.
So good morning all. I am Dr. Anuja Patil, and we all must have read about botulinum toxin in our MBBS time. But today I am going to teach you about
slides. Where are the slides?
Please, let's know your name first for the judges. Tell your name first to the judges.
Yes.
Otherwise, they won't put the marks.
No.
Anuja, no, don't worry. It's okay. She'll put the slides. We'll start the timer again.
No.
So good morning again. I am Dr. Anuja, and we all must have read about botulinum toxin during our MBBS time. But today I'm going to teach you about botulinum toxin use in ophthalmology. So as we all know that it is an exotoxin which is produced by Clostridium botulinum, which is a gram-positive anaerobic bacilli, and it is the most potent toxin. It is also responsible for a deadly food poisoning called botulism, and it is used in ophthalmological diseases as well as in treatment of the screen wrinkles. So it is a 150 kilodalton structure with a polypeptide chain having a light and a heavy chain linked with a disulfide bond. It has 7 serotypes, of which type A is the most potent serotype, followed by B and F. Coming to mechanism of action of botulinum toxin, so the heavy chain would bind to the presynaptic terminal and the light chain would cleave the SNAP25 protein, which is responsible for fusion of the acetylcholine vesicle to the presynaptic membrane and its release in the synaptic cleft. So this prevents its release and hence resulting in the flaccid paralysis. Its action peaks at 2 to 3 weeks and its effect reverses in 2 to 4 months. Therefore, it is very essential, students, to tell the patient that the action will take long and it will last only for 2 to 4 months. Coming to its preparation, so type A serotype and B serotypes are used in ophthalmology, of which type A is the most potent serotype and has a prolonged effect, whereas type B is a faster in action, but it is very irritant. Coming to its clinical applications, so it's used, it has functional uses like facial dystonias, like benign essential blepharospasm, hemifacial spasm, chemotarsorrhaphy, also in functional epiphora and senile entropion and strabismus. Coming to facial dystonias, so these are basically involuntary, repetitive, forceful contraction of the muscles. When it involves a single quadrant, it's myokymia. When it involves 2 quadrants of the orbicularis, it's benign essential blepharospasm. When unilateral facial muscles are involved, it's hemifacial spasm. And when all the 4 quadrants are involved, it's mixed syndrome. It also has cosmetic uses, as already discussed, that it is used in treatment of the skin wrinkles as well. So coming to the reconstitution of the botulinum toxin, so we basically take a 2 ml disposable syringe and we load a 0.9 ml preservative-free normal saline in the 2 ml syringe. We also need to basically use a 24 gauge needle in order to fill in the 0.9 ml preservative-free saline in the syringe, and then we need to inject it in the vial containing botulinum toxin. So this is present in the lyophilized powder form. We need to gently mix it, and this reconstituted drug, we need to load it in the 1 ml tuberculin or insulin syringe. And finally, we need to put a 30 gauge needle and we are ready to use. So in benign essential blepharospasm, these are the 6 sites in which we inject on either side of the eye, 2 above the 2 on the upper lid, 2 on the lower lid, 2 above the brow. This is the correct way of injecting, just perpendicular to the site of injection. In hemifacial spasm, additional to the benign essential sites, we also have to inject in the 3 different sites. So on the right side, we have this right-sided hemifacial spasm patient. Post-Botox, it showed excellent result. We also need to can inject it in functional epiphora in the palpable part of the lacrimal gland, and in strabismus in case of small angle deviation or in case of acute deviation, we can inject it for a temporary relief. Cosmetically, we can use it in brow lift, crow, feet, as well as in glabraritis. We have already discussed, and these are the sites where we can inject it. Coming to the side effects, so we can inadvertently inject it in the periosteum. Also, it can result in ptosis or bruising at the site of injection and dry eyes. So these are all mild and temporary side effects, and they can go off very easily. So thank you, and I would like to take questions from my students.
Students, question?
Students, questions, please. Delhi. She's from Delhi.
Ma'am, can we, do you have to use Botox always for squint? You said that you use it in strabismus. So I didn't understand, how do you use it in strabismus?
So basically in strabismus, in case where we have a very small angle deviation, especially we use it in case of congenital esodiation. So when we want to wait for surgery, so before surgery we can use it as a temporary measure in order to prevent amblyopia in such patients. Or if at all we have a patient with acute concomitant strabismus, in that case the patient would have a complaint of diplopia. So in that case, to relieve that complaint, we can give it as a temporary measure. Basically,
can we use it in paralytic squint also, ma'am?
Paralytic, we can use, again it's a temporary, paralytic is again acute in onset, so that would also have a diplopia as a complaint, so we can use it as a temporary measure.
Thank you. Now the marks. So 7, Dr. Gandhi, 7, Dr. Anil, 8, Dr. Chitiyal, 7, Dr. Kirti, and 5, Dr. Bishwas. So this is the last team of the first round, and that has been taken up by the hosts themselves. They wanted to come last and greet you all for this wonderful conference. Dr. Randir will be the mentor representing the state of Bihar. Dr. Randir, over to you.
Thank you, sir. I welcome, being the host, I first of all welcome you all to this place, the place called Bihar. It has been a land or seat of, wisdom from the beginning itself. You all know that 100 kilometers from here lies the Gaya, wherein the Buddha got its enlightenment. I think the hall will get enlightened by our, brilliant teachers, Dr. Shivani and Dr. Neha. So, both of them are doing their senior residency from AIOCMTC1 Patna, and I think they will teach you the real lesson and will give you the enlightenment. And I hope we, with the limited resources, we, the Bihar people, have been able to hold this conference to the maximum we could have. And if there is any fallacies, I'll ask for the forgiveness for that. Thank you.
I think 3 cheers to Patna for the for the wonderful conference that we have here in this beautiful city of Patna. And they just had a OT cap. Now we have the Santa Claus cap here. I think now over to you.
Good morning, students. Despite cold, I can see a very good attendance. I'll start the talk. So I will be dealing with orbital blowout fractures under these headings. So what exactly is a blowout fracture? What is the meaning of the fracture? Fracture of one or more of the walls of orbit caused by blunt trauma. That can be a RTA, that can be a assault, that results in a blowout fracture. So why blowout? So basically, when they're displaced fractures, displaced bony fragments are displaced outward from the orbit. So that is blowout. So we can have a blow in also. So depending on the intactness of the orbital rim, it can be a pure orbital fractures, or it can be impure blowout fracture. So coming to why does blowout fractures happen? Basically, it is a protective mechanism to mitigate the forces of the blunt trauma to save the intraocular structures. So coming to the classification, so we have the classification according to the site which sustains the maximum trauma. So it can be a orbital floor fracture, which is the commonest. It can be a lateral wall, it can be a superior wall, it can be a medial wall. So there are different theories that you must all know about the blowout fractures. It can be the various theories are buckling. So what exactly is buckling? When a force happens and the structure buckles under pressure, it is buckling. So whenever the orbital rim sustains the force, it buckles and results in fracture. So what is retropulsion? So retropulsion is basically when the eyeball takes the brunt of the blunt trauma, and the forces are transmitted via the hydraulic forces and results into orbital trauma. So clinical features will include restriction in the extraocular movements resulting in diplopia. It will be enophthalmos, it can be a hypoophthalmos, or it can be infraorbital anesthesias. You can also have patients with black eye. So any trauma patient, when he comes to our ER, we have to have a general evaluation and a proper documentation. So the evaluation will always consist of a full ophthalmic evaluation consisting of BCVA, consisting of a proper IOP measurement, consisting of Hertel's measurement of the proptosis or enophthalmos or a hypoophthalmos. We have to do a full orthoptic evaluation, which consists of a diplopia charting, Hess charting and everything, a full slit lamp evaluation with a good fundus evaluation wherever possible. So the radiological investigations will include X-ray in the Waters view, a CT scan, an MRI, will have a teardrop sign on X-ray. So a special entity is a trapdoor fracture when the displaced fragments with a hinge snaps back to its position and the orbital contents are entrapped. It will result in a trapdoor fracture, which happens usually in children. So we have a very emergency condition also, white-eyed blowout fracture, which happens in children, wherein the which is an emergency, and we have to go in for a repair ASAP, and because it leads to ischemia and fibrosis. So we have a non-surgical management and a surgical management. So there are only 3 indications where we need immediate intervention, whereas in a case of a white-eyed blowout fracture or where the patient has a oculocardiac reflex and a significant enophthalmos. So we have to have a surgery. So the goals are So the goals of the surgery are very specific. We have to disengage the entrapped structures. We have to go for restoring the oculo-rotatory functions. We have to restore the orbital volume. The surgical approaches will depend upon the site which sustains the trauma, which can range from transcutaneous to transantral. We have to go for the reconstruction materials also. So we have alloplastic and autologous graft. The complications of surgery can range from diplopia to visual morbidity, and we have to give a very specific post-operative care measurement, that is, the patient doesn't have to blow the nose. Thank you.
Thank you. Can we have the questions and then the marks before we wrap up the first round? Any question? Yeah, Dr. Anil.
Yeah, madam, can I ask a question? See, one of my friends had an injury while playing. So he went to the first doctor there. He suggested immediate surgery. Then they were skeptical about that. They went to another doctor. They said, we'll wait for 2 weeks. Why is that? Which is correct? No, he was playing football, and one of the friends' elbow went and hit his eye.
Use that mic. I think the mic is not working. You can just
Please
other
change
mic.
your mic. Change your mic.
So now so basically it was a blunt trauma, so we need to have a radiological investigation for that person, preferably a CT, to see what is the damage and what is the extent of the damage and what are the orbital contents that are being entrapped or not. Hopefully the first doctor would have had a documented full ophthalmic evaluation. So everything will depend on the radiological evaluation. If there is a trapping of the inferior rectus, or if there is trapping of the when the orbital fat gets incarcerated with significant inferior rectus involvement, so there we have to go in for an emergency surgery.
Dr. Very nice lecture. I just want to question, ma'am. If I am playing tennis, table tennis, if I'm playing badminton, if I'm playing football, and if I'm playing cricket, any injury of which one is more likely to give rise to a blowout fracture? Badminton, tennis, football, cricket.
So it would be a tennis ball because it is a 4 to 5 mm object which is going to cause a trauma, going to give a trauma to the eyeball and can result in a retropulsion forces and will result into blowout fractures.
No, but the fans can fight after the match also, no? So that can be anything. Okay, can we have the marks? 7, 6, 6, 5, 6. Thank you, Team Bihar. Now the judges are going for a strategic meeting now to decide what should be the strategy for the second round and the questions. 3 minutes for you. And by then, we will have only 3 minutes. You can, if you want their QR code or bank account details, we'll send it to you. You can, 3 minutes, you can decide all the, how to share the prize. We'll have the marks.
Other children here talk something about
announce the marks first.
Oh,
Okay, Dr. Nilima will announce the marks.
Good morning, everybody, and congratulations to all the students who have done so well in such a short time. A round of applause for all the students, please. We have already entered the adventure or the roller coaster ride of Teachers of Tomorrow, and I hope next year is going to be a bigger event than already that has been there. So I'll announce the marks. So starting with Team Gujarat, it's 26. Orissa is 42. Please have a round of applause. Team Kerala, a big round of applause, 44. Bihar is 33. Maharashtra is 31. Jharkhand is 28. West Bengal is 41. Assam is 32. Rajasthan 29. Delhi 34.
Wow, that's very, very close. I think
Karnataka is at 40. And Telangana is 37. So any guesses who's at the third position? Any guesses? So the first candidate, so the student who's at first position is from Assam. Sorry, the Kerala state, that is at 44. Then there is...
Who is that? Who is that?
Alan.
Alan. Alan, come, take a bow for the first round. Stand up. Where is Alan? He's gone. He's ROP with the judges. Okay. Arvind, so how do you think the program is going on?
It's really great. Can I have the mic?
No, 1 minute.
It's a great program, and being a teacher myself, I always believe that I know nothing. So it's an ever-learning process, and to see the young guns, they are performing so well, so confident. They were presenting their talks, so it's really amazing, awesome. Hats off to you, all of you. Congratulations, you all are winners.
Parikshit.
Now, Teachers of Tomorrow is something Dr. KP and his team have been doing in Karnataka for many years. We have done it twice in Maharashtra, but I think Dr. Partha saw it for the first time in Kerala, so he has a soft spot for that. But one of the aims of the AIOS is to build up the new generation and to make them more capable. And of course, they are extremely dynamic and talented, and they have some chutpas. I mean, you could see them ticking off Dr. Kirti and Dr. Titial, which was quite something. I mean, I loved that. I mean, I would give more marks just for that. So again, big congratulations to all of you and all the best.
I think our students always learn a lot. They learn from the best teachers. They learn from the not so good teachers as well. And they know how to give those answers, what they have learned. So we all are proud of our best teachers and we try and emulate them. And I think all of you who are doing it, you would have someone in mind that this is the person I'm going to emulate. This is how I'm going to talk. This is how I'm going to stride the stage. Things like that. So that's the essence of everything here. And I think, you know, by watching your colleagues, and this I'm addressing the youngsters, by watching your colleagues, you really know, yes, this guy has really worked hard. That guy has worked very hard. And this is how, you know, we learn from each other. And I think we also as teachers in our own capacities are learning from each one of you. Are learning from each one of you. And that's going to be the essence, because the learning pattern, what we had 30, 40 years ago has changed. And that's what we want to emulate for you. So it's not only for the teachers of tomorrow, but it's also for the teachers of today that we have this session.
I think it's equally important that Dr. Partha and the AOS has given a platform for all the youngsters. It's so unusual that a national body actually gives so much importance to the postgraduates, because there are so many programs already in a conference, and this probably will set a stage to kindle the interest. I think this program is going to be a big hit. From now on, all your students will be sensitized. The mentors will be sensitized. There will be now a better competition in future with so more new features added. We are going to make it more entertaining as well as more educative. I think all the students here who are presenting, obviously we learn a lot how to be a good public speaker. You can take the tips on how to present a PowerPoint, how to present to a crowd, how to make it very interesting. I think this will be a learning for all of us, as Dr. Partha said.
Prakash Marathi, sir.
Farouz.
Yeah, excellent. So very impressed with all the teachers of tomorrow. So being a teacher, I think we are also learning a lot. Like the way I learn most of the time is when I teach. When a student asks me a question, there are certain things that I go back and read. So being a teacher is also a great learning. As Dr. Partha said, we always have someone in our mind where we emulate, to be very honest. So when I present something and someone comes and tells me, you speak exactly like Carol Shields, I am so happy. And I really did. I really did try to, catch few things from her, the way she presents. And she's an amazing teacher. So there are certain times where you really unconsciously emulate the best of the teacher. That's someone that you have really got inspiration and someone that you really adore. So I think, yes, and I'm sure all of you have learned, Shifali, being in oculoplasty, you have learned more about HIV, right? So teachers learn, and yeah, so teaching is the best learning, And congratulations, everyone.
Hello, good morning. Good morning to all. I think it's Sunday morning, last day of the conference. This is the first midday conference of AIOS. There are various conferences every year. There are various scientific committee chairmen, scientific committee members. So they should have some innovative ideas. It's not like all those didactic lectures and routine conferences. Most of the delegates, what they say, that everything is there on Google, and otherwise they learn in even their local conferences, webinars and seminars and everything and CMEs. So something new has to be there in the conference. And that something new has been innovated by Dr. KP and by this doctor. Absolutely. And Dr. Partha has taken this forward and asked every state to bring a team. Even in Maharashtra, we had 2 teams. So there was little bit confusion whether to send 2 teams or not. Previously, we thought probably there will not be a good response. But at the end, many more states could participate in this sort of session. And I think it was wonderful. 5th September is the Teacher's Day. What we do on that day, probably students, they take the role of teacher. Here, students, they are taking the role of teacher, and they are trying to teach the teachers, and that particular role was observed. Even the marks were given, and fantastic innovative idea. And I am thankful to all of you for taking such sessions in the conference. And this is the way our conferences should move along. Then and then only probably the delegates will come and conferences will be popular. And it will be justifiable to have many more conferences in India along with AIOS and midterm AIOS. Thank you, Dr. Partha, Dr.
Thank you very much,
Dr.
sir.
KP.
Thank you. Now I'll take a quick call on our judges. And I'm going to tell me as the first person of this very important question, who do I emulate when I'm trying to teach? My answers are 2 teachers of mine. One, here in Patna, my professor of surgery, Professor Ahmed Abdul Hai, phenomenal teacher. I cannot think that anybody could be better than him. And the second teacher of mine, Dr. S.S. Badrinath. These 2 teachers have taught me how to speak. I'm just 1/100th of what they are, but that's it. Rashmin, who do you think is your teacher whom you would like to emulate?
Whom do you copy?
Dr. Badrinath.
Dr. Badrinath and Dr. Narsingh Rao.
Yes,
Dr. Narsingh Rao used to tell me, this slide, it looks like pink. Then he starts to look at the pink color, whether it's a deep pink or light pink. That way he will start from the very beginning.
Sir, which teacher you normally echo or copy or emulate when you teach?
What should I say? Normally, I don't copy anybody. For me, my best teachers have been 2 people. One are my students, they are my teachers. Today, I'm standing here because of my students only. Every day,
Yes,
I take
sir.
it from them. And one of them is sitting here, Panita Sahai. They've been my best teachers, truly speaking. And second is my patients. I've learned from those 2 people.
Yes, sir.
Patients and my students, nobody else.
No, we were just trying to again refocus on which teacher has a great influence on you that you trying to emulate them.
Sir has been my teacher, but hasn't influenced me that much because I'm not that good a teacher as sir. My first teacher, whom I remember all the time, is my English teacher. The way she taught me Shakespeare, et tu brute, then false Caesar. I can still see her standing. She made us love this subject. As a teacher of ophthalmology, my aim is to be like Mrs. Ghosh, God help, bless her wherever she is, because I want my students to love the subject. And that love of thing which she gave me. Second, I agree with sir, my students, the feedback. Madam, this was this. Like, you know, a lot of you people have used something called a set induction. The first slide is captivating. A lot of us in the initial have very busy slides, very theatrical teaching, and then in the end, my children and my students, ma'am, keep it to the point And best are the ones will say afterwards, I am not teaching to teach or to propagate myself, but to teach the students how much am I reaching to them. So keep it simple and keep it pertinent to the point. That is why the best teachers have been my students.
I think before the last comment, the Gujarat people can take the stage, the second round, and the Maharashtra on the other side. Nice, sir. I think till they are getting ready, I think when a teacher teaches, what is the parameter that he can actually see? You always have to assess the audience response. Don't keep teaching to the wall or to the laptop screen. So look at the audience. Huh? Okay. So keep assessing the audience response. Okay, they should not open their mobiles and start searching for social media when you're teaching. So that is the thing. So get a cues from the audience when you're talking. Dr. Anil Radhakrishnan, the question for all the judges is, who is the teacher that you have been greatly influenced by, and when you're teaching, like you tend to almost emulate them?
Yeah, I think because I think where you have trained, that obviously influences where like how your thinking would be. I'm very much influenced by Dr. G.N. Rao, even though he has taken very few classes to me. Then I think in the postgraduate period, I would say Dr. Thaimagundalu K. Ramesh, who was my teacher. Yeah.
Dr. T.K. Ramesh from Minto Ophthalmic Hospital, Bangalore. I think he's one of the greatest teachers of present times. So now we go to the round 2. Okay? Gujarat. The judges, now this is the second candidate from Gujarat.
Good morning, students. I hope you guys are fresh from the break. So let's start this topic of glaucoma drainage devices, understanding the nuances. It's a great topic and it's a huge topic I have to cover in 4 minutes, so I'll be a bit quick about it. What are glaucoma drainage devices? They are basically devices that are used to drain aqueous from the anterior chamber into a reservoir. So any idea which was the first device which was used to drain anterior chamber? It was literally a horsehair. It was used in 1906 and followed by 1912, Zorab, he used a silk thread as a set-on device. Later, titanium and gold threads were also used. Coming back to the definition, this is a very modern day definition and I'd like to focus on 2 things, drain and into the reservoir. So that becomes the basis of the modern day drainage devices. So from the horsehairs to silk thread to modern day devices, there has been a huge journey of the glaucoma drainage devices. So how did it start? It started in 1970s when Molteno gave the first basis of tube and a reservoir device. It was followed by 1990 where Barwelt gave his model. Krupin gave another model in 1990. What was the stark difference between Barwelt and the Krupin model was that Barwelt and Molteno were non-valve devices, whereas Krupin was a valve device. Coming to 1993, Mateen Ahmed gave his valve device, and that has been used frequently now. And in 2013, our indigenous product, Oralab Aqueous drainage device was given, and 2013 it came into the Indian market. So how do the glaucoma drainage devices work? Basically, they form a fibrous capsule around the plate, and there is which acts as a reservoir. The aqueous pools in it, and it goes into the subconjunctival space by passive diffusion and absorbed by lymphatics and capillary. Coming to this is the diagrammatic representation where you first see how the valve is placed, then you go to the coronal section where you see the tube and the plate, then you see the drainage of the aqueous into the reservoir, and you see the reservoir expanding. And this is how the final outcome looks. Classification, there are types of, it can be based on types of plate which are rigid and flexible, types of material which can be silicon, polypropylene, types of opening, valvular, non-valvular. Coming to the devices, I'll go quickly through the 4 devices that I'm discussing today. This is the first GDD based on which all the GDDs till date are given. Here are the different parts of the glaucoma drainage devices, which is tube is made of silicon and plate is made of acrylic. There are suture hole where can be the plate can be sutured to the sclera so it does not move. These are various types, these are the various parts of the multi-node devices, where dimensions, these are not really important for the class today. Aqueous drainage is directly proportional to surface area, so the more the surface area, more the aqueous drainage happens. This is a Barwell device introduced in 1990s. It's a single plate, no valve device. Ligation of the tube is necessary to prevent hypotony. Modification is larger surface area, more diffusion of aqueous, and better IOP control. Placement is between two recti, so that can cause various complications. These are the various models which are present, 250, 350, 500, which are based on the surface area. This is an indigenous product, Oralab, manufactured by Oralab, Madurai 2013. That model based on Barwell 350. This has lateral wings and fixation holes, plates. The curvature of the aqueous Oralab is lesser than the Barwell. Krupin is another valve device which is based on the vertical and horizontal slits are given, which causes the valvular action. Ahmed valve is based on the elastomeric tube, which causes the valve function. These are the various complications which are common to all filters, common to all type of GDDs, and common to the non-valve, that are hypotony and diplopia. When to use refractory glaucoma and secondary glaucoma. So, does the class wish to know whether to know? I'll just skip that part. And thank you.
Thank you. Thank you. Class, any questions?
So, very exhaustive topic covered in 4 minutes. Would have been preferable as a teacher, I'm just talking that we have talked about the valve, the non-valve, and the current perspective rather than going the historical perspectives, but that's okay. And as a student, I wanted to ask you, sir, what is the complication of a tube shunt, which almost always happens, which doesn't happen in a trabeculectomy?
Sorry, ma'am?
Or what complication is very ubiquitous to most tube shunts?
Ma'am, hypotony of the...
No. Hypertensive left phase.
Hypertensive phase.
Hypertensive phase, yes, ma'am. That happens because of the release of inflammatory cytokines in the aqueous, and that
so
causes
you have to warn the patient before that's going to happen, so then it doesn't come as a surprise. Okay.
No, why does hypertensive phase happen? Why? Why it happens? Why the IOP rises?
So, because the cytokines in the aqueous, they cause early fibrosis of the capsule.
Yeah,
and
there is
that
an
prevents
encapsulation
encapsulation
that happens. Okay, well done, Dr. Pawan. Now, Team Maharashtra, Dr. Anju Bansal, it's your turn now. We have the marks from the judges. 7, 6, 6, Sarji, marks. 6, 6, Anil, okay. So Team Karnataka will take stage here on this side. Now Dr. Anju Bansal, the second candidate from Maharashtra.
Good morning, students. Let's discuss about malingering today. What is malingering? It is defined as subnormal vision with no underlying pathology, which can sometimes be associated with ocular pain, discomfort, photophobia, and blepharospasm. Based on intentions, malingering is 4 types: deliberate, worried imposter, impressionable exaggerator, and suggestible innocent, which can be triggered due to existing poor health, psychological events, and blind trust on Google, that is cyberchondria. Aim is to assess and demonstrate better vision than what is claimed. Evaluation begins with detailed systemic and drug history, which can cause organic vision loss. More important is the psychosocial history responsible for his altered behavior. Patient's response to offered glass of water and his vision-related behavior before and after entering the chamber can also give a clue. Be on a watch out on an overprotective, aggressive, and attendant. These basic ophthalmic tests, especially the pupillary reflex, rules out the organic causes. If these basic tests come normal, do OCT, which can pick up the subtle retinal causes of poor vision. If OCT is also normal, do proceed with the new perimetry. These classical neurological defects rules out malingering. Poor reliability indices and Clover-Leaf pattern suggest lack of cooperation. After this special ophthalmic investigation, If your index of suspicion is more towards the neurological cause, then do neuroimaging. If neuroimaging is also normal, then how do I proceed further? This table suggests the subjective and objective tests to be done for a patient. In a conversion or a hysterical patient, confusing with utilizing lenses can befool a naive malinger. The principle of the fogging test is to fog the better eye while checking the visual acuity. In a uniocular malingers, using this word-for dot test and the front test can also help you out. In a uniocular malingers, first, diplopia is induced in the sound eye and the blind eye is closed. Patient is confused. He is convinced that he is seeing the diplopia with the sound eye. Now, open the blind eye and strictly remove one of the prism. If the patient still reports a diplopia, it means he is having the binocular vision. Binocularity and the good vision are essence of the stereopsis. So we can use this test. For the binocular malingers, they can't control their surprise reflex after seeing the mirror in the reflex. And also they may feel not able to touch their fingers, while the blind people can do that effortlessly. Similarly, putting your signature does not need the good vision, whereas malingers will show inability to do so. Best objective way to pick up these binocular malingers is the absence of nystagmus on the oculocephalic reflex. That means the intact correcting mechanism. And also, the absence of occurrent drum will reveal the nystagmus. And people feeling the visual field loss will show the tunnel vision, which means same loss of the visual field at the variable distance. That means malingering. So students, learn these tests and learn to demonstrate. But how do I manage these patients? First and foremost thing is, don't confront this psychosocially disturbed patient. Secondly, don't be judgmental. Third, all of the things you need to do in the absence of a patient, and later you can call the attendant and explain in a version that is palatable to a patient. And especially emphasize on a good prognosis. So students, if you have any question, raise your hands and ask one by one. Thank you.
Yes, Dr. Anju. Well done, well done. Any question?
So the
from
cause
my
of
student?
malingering, that needs to be addressed. Okay, madam.
Ma'am, very good question. In the OPD, if you have an OPD of 50, 60 and you have one malignant, what test can you do in the OPD? Just within seconds.
My test will start from the patient first entering in the OPD. I will notice
Walking,
his behavior.
observing the walking.
Yes, ma'am.
Second?
Avoiding the obstacles or not.
Okay, walking, navigation. What is single test you'll do to break the mirror? The very good thing which I was giving a way out. So what test will you do? In the OPD, in the ward?
Offer a glass of water.
Menace reflex.
To see his hand.
No,
Menace reflex.
Suddenly putting the hand.
Okay, now let's go for the marks. Please, judges.
The Jharkhand team to be ready on that side.
7 and a 9 and a 6 and a 6 and a 7.
Hold the thing. We are taking a photograph. We are documenting this. We are not, Zorat, you are not malingering. Okay. Right. So now the second participant from T Karnataka.
They are coming with a lot of things on stage. Shark. What is that?
Wait. Yeah, Dr. Ashwita Alva. I'm not a judge. Don't be judgmental.
No, this is such a transparent system you have seen anywhere in the world?
No.
No.
The judges go for a break and decide and come back. Twice.
Capacity has to be clarified by Dr. KP.
Okay. Yeah, can we start? Yeah.
I'll just check.
Dr. Partha is getting a little nervous. because time is going by. Okay. Time is starting. Please.
Most of you must have watched this heart-wrenching 2004 Marathi movie, Shwas. Can I restart?
Okay, please, can restart the timer. Wait. Yeah, start.
Most of you must have watched the 2004 heart-wrenching Marathi movie, Shwas. It's about this little boy diagnosed with retinoblastoma. Quite unfortunately, he had to lose both his eyes in order to save his life. Were this movie to be directed in this era, probably the results would be more promising. A very good morning, all of you students. Today what I'm going to teach you is 100% coming in your YOC. What I'm teaching you is the recent advances in the retinoblastoma management. Retinoblastoma is one of the most common primary intraocular tumor affecting more than 2,000 children in India. There has been a paradigm shift with what started with only 5% survival, went through enucleation, EBRT, and the big boom globe salvaging therapies came with the intravenous, intraarterial, and intravitreal chemotherapy, bringing it to a 98% survival. So Dr. Gandhi, tell me, what is the golden principle in treating any carcinoma? Okay, let me take you through it. First is always to rescue life, then restore the organ, and finally reclaim the vision. Intravenous chemotherapy downstages the tumors and effectively treats high-risk and metastatic cases with several drugs. It shrinks the tumor towards the side of its vascularity, improving the macular and foveal area, thus improving the vision. However, a high dose of the drug is required to treat group D and group E tumors and large orbital retinoblastomas. So imagine such a large tumor invading into the surrounding structures, quite life-threatening. The historic moment has come to burst them. These group of tumors are the cannula passing from the femoral artery directly into the ophthalmic artery delivers 10 times more amount of the drug, being very effective for the tumor but with least systemic side effects. They effectively treat all the groups of tumors using the drugs melphalan, topotecan, and carboplatin. This 2-year-old infant who had a group D tumor measuring 10 mm in size regressed to a mere 4 mm after 4 cycles of intraarterial therapy. 90 to 100% success has been seen in group B, C, D tumors with a 50 to 60% success in group E tumors. We have been able to achieve a very good eye salvage from 5 to 95%, successfully treating choroidal invasions and optic nerve invasions as well. Look, vitreous seeds, so hard to capture them, right? These retinoblastoma seeds were effectively treated with topotecan and melphalan drugs. This patient who went through 3 to 4 cycles of intravenous therapy was finally effectively treated with the topotecan drug. Intravitreal therapy has been able to save 78% of the eyes that were otherwise planned to be enucleated. Transpupillary thermotherapy has been enhanced with ICG. So what do you think the future holds? Nanoparticles coated with gold and other inorganic materials have been coming up. Gene therapy, oncolytic virus are in the phase 1 study. Probably one of you are going to bring in the near future. Okay, now let's look at these 3 kids in our OPD. The first one was recently diagnosed with retinoblastoma. The second child who had gone through 3 cycles of intravenous therapy, and the third child who not only saved his life but also his vision. So kids, what do you take from this class? Retinoblastoma is not all doom and gloom, as we are on our way from giving them vision and watching them bloom into visionaries. Thank you.
Thank you very much. Wonderful, wonderful. Over to the judges for questions.
So, in our country, at this point of time, what treatment modality you will advocate?
Very, very good, sir. Very, very good. I'm so proud that all our brilliant students have their inquisitive mind running. So, the best modality of treatment will be the intraarterial therapy. It effectively treats the thing. However, it is quite expensive, so the poorer communities do have a trouble in taking them. However, give the best opportunities, bring in these opportunities for these kids. Thank you.
Thank you very much. So, over to the judges for the marks. A 9, and a 9, and an 8, and a 8, and an 8. Okay, high marks indeed. Thank you very much. We'll have the Jharkhand team there, and West Bengal team can come here to this side. West Bengal team, you can come to this side. Yeah. So we have Dr. Shubram. Simple limbal epithelial transplantation. Okay. Can we start the timer? Yeah, start.
Good morning, everyone. Now, today I am here to present you the topic of first of all, limbus. As we all know, it marks the junction of the cornea and sclera, and in slit lamp, it is seen as a brown color tissue between the cornea and the sclera. Now, it harvests the limbal stem cells, which are long-lived cells and have a long cell cycle time, and they have a unique property to proliferate, but not to differentiate into other cell types. So, and one of the main function of these stem cells is to provide the barrier for cornea to prevent the conjunctivalization. Now, in the stem cells, they are located in the limbus, in the palisades of Vogt and limbal epithelial crypts, and these cells are more prevalent in the superior and inferior part of the limbus. So, now coming to a limbal stem cell deficiency, it can be of two types, that is partial limbal cell LSCD or total, which can be unilateral or bilateral. Now, in this picture, we could easily make out that due to loss of the limbal stem cells, the vasculature is, blood vessels are started to spread towards the cornea. Now, coming to the causes, this could be hereditary or primary, which includes aniridia, keratitis associated with multiple endocrine deficiency, epidermal dysplasia, neurotrophic keratopathy, chronic limbitis. While under acquired or secondary causes includes chemical or thermal burns, Stevens-Johnson syndrome, contact lens-induced keratopathy, reduced radiation, and PKC. Now, in PKC, there is not deficiency; it's actually dysfunction of the limbal stem cells. Now, what are the sequelae to limbal stem cell deficiency? Now, if the limbal stem cells are lost, then the cornea would clearly step towards the vascularization. There would be conjunctivalization, and if left for too much long period, they could even proceed towards the symblepharon formation. Now, coming to the symptoms, as the epithelial cells of the cornea are lost, and there is a pannus formation over the cornea, this would lead to decreased vision. There would be, due to loss of the epithelial cells, there would be recurrent episodes of pain, photophobia, which would ultimately result in chronic inflammation and redness. Now, for this, to overcome this, the simple limbal epithelial transplant procedure was introduced by by an Indian ophthalmologist, Dr. V.S. Sangwan sir, in 2012, which in this technique, there is a in vivo expansion of the autologous limbal stem cells that can be harvested from the contralateral healthy eye. So, this technique of SLET could be divided in two parts, autologous and allogenic. In autologous SLET, limbal tissue is harvested from the contralateral healthy eye of the same person, while in allogenic SLET, the limbal tissue is harvested from the cadaveric or any other relative live-related eye. So, what is the most prerequisite before the surgery? The patient should have the moist eye, as it is a contraindicating the severe dry or keratinized ocular surface. The examination includes status of eyelids, symblepharon from extent of LSCD. Now, in technique, the limbus cells is divided into 12, is harvested from the good eye, and it is divided into 10 to 12 parts, and the pannus is removed from the cornea, and is divided, amniotic membrane is spread and fixed with fibrin glue, and the pieces of the limbus stem cells are spread all over the cornea and fixed with fibrin glue, and large BCL is placed all over the cornea. Now, this SLET is helpful in the epithelialization in the during the post-excision ocular surface or during the chemical or injury. It advantages of it are that it is a single stage procedure and cost effective, while the disadvantages include the late possibility of the late failure. Now in focal eye, now in the donor eye, complication include focal LSCD or pyogenic granuloma, while in the recipient eye, the complication includes the loss of SLT, amniotic membrane disintegration, microbial keratitis, and the possibility of the late failure. Thank you.
Wonderful presentation. Over to the judges.
Sir, it was a very good class on a limbal stem cell deficiency rather than SLET. I want to know, I'm very curious to know that once the corneal surface improves, sir, how do we know that this is not the conjunctival epithelium or it is the, the limbal cell epithelium?
Once the tissue is repaired, then there would be vascularization of the tissue has been removed.
Yeah, how would we confirm, sir?
So epithelial tissue is by staining, fluorescent staining. Under the fluorescent stain, we could confirm that the epithelial tissue has regained on the cornea.
Okay, I think a student will answer better.
Okay, can we have the marks, please? Judges, please. A 5 and a 5 and a 5 and a 6 and a 6.
Thanks.
Okay, now Dr. Ashish Bujumdar, senior resident from RIO Kolkata, lower eyelid reconstruction.
Good morning, students. Today I am going to teach you lower eyelid reconstruction. Not every one of you over here are going to be an oculoplastic surgeon, but this is an important topic. Why? Because you can see this in your day-to-day life. So I am going to brief you a basic of the lower eyelid reconstruction. So look at this beautiful lady. Suppose she come to you with this kind of defect to you. What will you do? Before going to see, you need to know why will you do, when will you do, and what will you do. So why will you do? Because you need to protect the cornea. Then you need to maintain the support and the shape of the eyelid to maintain the tear film. And obviously to maintain the aesthesis. So for that you need to maintain the symmetry with the contralateral eyelid. So when will you do? This is an immediate procedure to do. Why? Because you don't want this thing, exposure keratitis. So you have to do it within 1 week. So what to do? Before going that, you need to know a bit of surgical anatomy. Lower eyelid consists of anterior lamella, which consists of skin and muscle, and posterior lamella, which consists of tarsal plate and palpebral conjunctiva. Now, if a defect has come to you, you have to assess it as a 3D structure. For that, you need to see location, size, the depth, and the skin laxity. You need to do additional evaluation of the lacrimal system and the contralateral eyelid evaluation. So now the question comes that what surgical options do you have? For that, you need to know that what structures are missing and what other structure can be replaced by what. So as an option, you have direct closure, you have graft, you have flap, combination of graft and flap, and the secondary intention. Suppose you have skin defect, right? So if there is a skin defect, what you can do? You can do a full thickness skin graft. If there is a cartilaginous defect, like if there is tarsal plate defect, you can use cartilage with this. What cartilage you can use? You can use auricular cartilage. Now, any patient come to you, what will you do? Anything you want to do? No, there is an algorithm. Students, this is the most important slide you need to see. That first, a patient if comes to you, what you will do? You will see whether there is tarsus involvement or not. If no, then go for the anterior lamellar reconstruction. How you will do? By secondary intention, skin graft, skin flap, and direct closure. If the tarsal plate is involved, that means it is a full thickness defect. So you need to see whether the defect is less than 1/3 of the eyelid. If it is, then see the lid laxity. How it is? If it is less than 6 mm, then go for the tensile flap. How it looks like? It looks like this. If there is a more than 6 mm of lid laxity, then go for the direct closure. How you can do? You can do by the primary closure, pentagon, or dog ear. If there is a defect which is 1/3 to half, then go for the defect type. If short and deep, then go for tensile. If long and short, shallow, then go for the Hughes flap. Now see if it is more than half, then what you will do, see the posterior lamella or anterior lamella defect. If posterior lamella, see the conjunctiva is there involved, then go for the Hughes flap. If tarsus, then do auricular cartilage graft. If anterior lamellar defect, then master cheek flap rotation. Student, this is 4-minute class. I cannot go long, so must read this thing, go home, this is your homework, go and study these books and these review articles, that will make you perfect for this.
And then only ask any question. Okay, over to the judges. Over to the judges.
And students, I have something for you. Here are the hands out. I'll give you to you. Go back home and read this hands out. Please, don't take it. I'll give it after class.
Oh, they are simple pages. You will not hand out.
Sir, what would be the, your teaching for opposing the lid margin? Which type of suture we should place so that we have a perfect opposition of lid margin, sir?
Yeah, for that I would come to you and show you few things that will help you to understand this. May I?
As a teacher, if he asks the question, then?
Sure.
Okay, can we have the marks, please, please? A 9 and an 8 and a 7 and a 7 and a 9. Wonderful, good marks. Or to Team Rajasthan, Dr. Sunaina is here. She is from Government Medical College, Bikania. She is a senior resident and you will be presenting on?
So low vision aids.
Yeah, low vision aids. I'm a retinal surgeon. I create a lot of low vision patients. So it's an integral part of my practice to have, same there. She's from Rajasthan.
So good morning, everyone. There is only a small talk about low vision aids. I'll try to make it concise. So by definition, low vision aids are low vision is the level of vision that prevent from performing customary vision activity with standard optical correction. And the low vision aids are the optical devices enhancing the residual vision. Visual function is the ability to perform important tasks requiring vision. And the measures are visual acuity, visual fields, contrast sensitivity, and color vision. And visual dysfunction includes visual disorder, that is deviation from normal, visual impairment, that is reduction of visual function, visual disability, that is reduced ability, and visual handicap, that is non-performance of activity. Categories of visual impairment include low vision and blindness. Low vision includes maximum less than 6/18 and minimum equal to finger counting 3 meters, and blindness include from 3 meters to the light perception. So why there is a need to prescribe low vision aid? Low vision aids are given for independence, increased adaptation for the daily activities, exposure to the enriching experiences. So there are types of low vision devices. It could be optical, it could be non-optical. For the optical devices, distance, intermediate, or near devices can be used. For distance and intermediate, telescopes are the most important devices that should be used that improve resolution by increasing the size of the image. The types that are used are Galilean, Keplerian, handheld, spectacle mounted, monoocular, binocular, fixed focus, or autofocus. The Galilean telescope that are used are consist of 2 lenses, that is one convex and one concave. It gives a magnified image but an erect image. And the Keplerian telescope or the astronomical telescope consists of 2 convex lenses. It gives a magnified image but it is real inverted, so we need mirror or prism to erect the image. A handheld telescope can be used, that is simpler, lighter, and cheaper, and spectacle mounted leads the hand free but gives a detailed view, but both way and cost are more. Monocular, binocular telescopes can be used. A monocular is used when there is a significant visual acuity difference between both the eyes, and the binocular is used when there is a similar visual acuity. Fixed focus is used for the patient with poor motor coordination, and focusable can be used when we need to reach far, near, or intermediate distance. Autofocus help in focusing automatically, but both way and costa more, so not the first choice. For near, high plus spectacles can be used, hand magnifier and stand magnifier or telescopic system can also be used for the near. Non-optical devices that can be used is a linear magnification, which increases the size of the image, lighting control, enhance contrast, reduction of glare and improving the physical comfort. Other devices like M-training can be used, that is help in walking by rotating the neck and see the peripheral object and make a view in their mind. Signature guide can be helpful for signing in the checks and small things. Notex can be used to count the currency as per the cut marks. So how to prescribe low vision aids? Firstly, determine the best correct visual acuity for the near or distance, then determine the visual acuity that the patient requires, and then calculating the magnification, and then aids, selecting the aids according to the characteristics of the device. When to prescribe it? At school age with visual acuity more than 20/200, a stand magnifier can be used or a handheld magnifier, and with a visual acuity less than 20/400, video magnifier can be used. Visual acuity with less than 20/800, braille or computer sound system can be used. So in the end, the only thing that is worse is, worse than being blind is to having sight but no vision.
Thank you very much. Thank you very much, Sunaina. It was a wonderful presentation. So now smart mobile phones are also used as a lot of low vision aids. Over to judges, please.
Yes.
Madam, you talked about for a prescription of a low vision aids, we have to decide the magnification. So how do we decide the magnification required for one particular person? How do you calculate the magnification required for a low vision aid? Suppose I want to go for a distance telescopic lenses.
We need to calculate the magnification by the visual acuity that is required for the patient, the visual acuity that is there for the patient divided by the visual acuity required for the patient.
Okay, just one thing which, again, as I mentioned, visual field was not mentioned. In the low vision also, visual field is extremely important in the criteria.
Thank you very much. Can we have the marks? A 6, and a 5, and a 6, and a 6, and a 5. Can the Kerala team get ready there? And here we have Dr. Avantika Das from Orissa. So she's a resident in JP Rotary Eye Hospital, Orissa. She will be presenting to us on cortical visual impairment. A great class, I would think. Can we have the slides and the timers? Orissa, sir, Orissa. You can go there.
Good morning, class. I think you all are pretty exhausted by all the lectures going on, one after the other. I'm going to be very brief. This will come as a short note. It is a very not that usual a topic, but just listen to me. Take home some very salient features. That would be it. So, cortical visual impairment. As you know, the visual pathway ends at the occipital cortex. So, after that, what happens? There is a processing pathway. So either it goes to the dorsal parietal root, or it can go to the anterior temporal root, where from we can know whether it is a object processing or spatial processing. So if that part is involved, we call it a cerebral impairment, not a cortical impairment. So patient might be saying to you from neuro department to rule out cortical impairment before they go on and check other part of the brain. So here, if ipsilateral retina or optic nerve is involved, it will be uniocular blindness, or if the chiasma is involved, it will be a bitemporal blindness, or beyond that, it will always be homonymous hemianopia. Special mention would go to the spy in the sky and pie in the floor appearance, which will affect the temporal and the parietal respectively. Beyond that, if it is involved, if there can be macular sparing if it is supplied by the MCA. So patients will come to you with the symptoms of visual loss, diminution of vision, and visual field defect. Signs will vary according to the location, or it can be done by confrontation perimetry. Anterior segment would be normal, so will be the posterior segment. Here important point is there will be no RDPD. So just seeing at the pupillary reflex and taking it to be normal, just don't say that patient doesn't have a disease. Most commonly it is seen in the children in case of trauma, congenital anomalies or ischemia. In adults it can be due to hypertensive crisis, due to head trauma, eclampsia, seizures, or due to metabolic causes like hyponatremia, severe hypoglycemia. Infections like HIV and Creutzfeldt-Jakob can also cause it. Melas and press can also be associated with it. So let's have a look in a case. A 58-year-old male, known case of a diabetic and a hypertension, with a history of stroke and cataract surgery, complained of inability to see the left side of the visual field for 1 month. Anterior segment, VCVA, color vision, all normal. Voila. Posterior segment, also normal. What to do? What to think? Is it a TIA? No, the patient was not improving in hours or so. Is he having a migrainous aura? It was not associated with headache. What are the other differentials? Is the patient faking? Might be. Let's see. Is it a toxic amblyopia? No such history. Patient can also have hemi-neglect, prosopagnosia, or simultagnosia. It can also be having complaints of peduncular hallucinosis or a blind sight. So we should be thorough with our investigations, especially metabolic profiles, to check for the causes. Next, MRI, HVF, and VEP will come handy. In our case, it was a left homonymous hemianopia, and the MRI revealed a PCA infarct in the right thalamo-occipital region. So, treatment was the management of the cause with training and rehabilitation. These are the associated symptoms with it. Class, you should be thorough with it for the exam. So, take-home messages. The problem is at the software level, not the hardware. Sometimes, as an ophthalmologist, we just see the eyes, but we should also be looking beyond it. Thank you.
Well done. Well done, Avantika. So,
Thank you, sir.
The judges, one question, and the marks. The second person from Kerala to be ready on the other side.
Yeah, so Antika, you did a great job as far as teaching is concerned. Maybe there is a debatable part about the content as to how much of this would go into CDI and how much of this would be just a visual pathway defect. Remember, I didn't understand, how do you do confrontation?
I'll ask the patient, like in my case, I'll ask the patient whichever field defect he was having. So in confrontation test, the examiner should be comparing himself with the patient. So taking yourself to be normal, you can compare how much and the patient can be seen.
Okay, thank you.
Thank you. Can we have the marks? 8, 6, 8, 7. Yes. 7. All the 5 you got?
Thank you, sir.
Okay.
Thank
you, Dr. Avantika. Great job. Great job. So, the team Assam will come here. Get ready. Okay, on the other side. This is no, sir. This is Kerala, sir. No, this is Kerala. Now it's Kerala.
Kerala.
Dr. Lisa.
Lisa Maria George.
Okay.
Artificial intelligence.
Yeah, they're getting ready. So let's not waste too much of time. The other the state has to be ready on the other side and get ready with all the paraphernalia before the other things gets over.
So Kasturi, would you have participated in a session like this at AIOS?
Definitely, I would have loved it, and this is so interesting. Like being a mentor, I feel that I am more a mentee, learning so much from the excellent mentor that they have presented. So I should congratulate you and the whole team, and we should continue this every year.
So that thought is taken. So we have had it at AIOS midterm, and we shall have it at AIOS annual Kochi. Now the burden is on me. How, and my scientific committee, how do we put it in? How do we have 3 hours of uninterrupted session? But we'll do something about it. Balla is here. Balla?
Sir, I see this hall totally filled up in this dot, even when compared to OPL, to be very honest. It's totally full.
Yeah. I think it's a wonderful concept which has really taken off, and we really need to go a bit step further. And yeah. I think, and this generation, I'm really proud of each one of them, the confidence with which they are teaching. I think hats off to them. 3 cheers to all the teachers. All the teachers, I think, really wonderfully done, sir.
Yeah, ready kar do. If there is is there a technical glitch there?
Problem, we'll start with Assam.
Yeah, then we'll start with Assam, please. You get ready there. Genia Dev.
We'll have the Assam, then we'll come back to Kerala. 3 more. Bihar.
Genia Dev is going to talk to us about approach to disc edema.
So Anil sir, what do you think of the standard of teachers of tomorrow?
Yeah, I would like to echo what Dr. Mahipal told. I think the confidence level, especially among the first year residents, is amazing. That is something very important, especially sitting in Bihar, which is the old school of Indian education. I think the right message is going across.
Dr. Parvez Alam.
Thank you. Unparalleled. I was not expecting this thing. For the last 3 hours we are here and still learning. So hats off to all teachers of tomorrow, and this session must continue as Dr. Partha Biswas sir court martial is going on. I think this is going to rock all the sessions, and in all conferences it will be taken off. Thank you.
So wonderful. Thank you so much. Anybody else? Anybody else has a thought?
Can we have, which presentation are we having now? That's it.
Who is presenting now, finally?
Okay. Who is presenting? Approach to disc edema, Dr. Dr. Genia Dev from Assam.
Okay, so a very good morning to all of my bright students here. I'm sure you all must have been exhausted by now, but please recharge yourselves because we have a very important topic to discuss here in under 4 minutes, which is a very mammoth task for me. So I expect all of you to read up on it once I'm done, okay? So let's start. So when we talk about disc edema, what are we basically talking about? We are talking about the window to the brain. That is the intraocular portion of the optic nerve or the optic disc which we can visualize. Why is it so important? Because timely diagnosis of a simple thing on the first fundoscopic examination can sometimes be really important and even life-saving for the patient. So that's how important this topic is for today. Now, what is disc edema? It includes all the causes of active or passive edematous swelling of the optic disc. So there are 2 questions to ask yourself. Number 1, is a disc really edematous? Number 2, is the optic nerve function affected? So, what can you notice in almost most of the cases of optic disc edema? There are features like disc hyperemia, blurred disc margins, nerve fiber layer swelling, elevation of the disc, and the tortuosity of the vessels. So the thing to differentiate here is between a true disc edema and a pseudo disc edema, which sometimes is not possible only just clinically. So when we're talking about the causes of true disc edema, the first thing that comes to mind is a bilateral disc edema caused due to elevated intracranial pressure or the papilledema. We can have inflammatory causes like papillitis, we can have vascular causes, and we can have compressive neuropathy. What are the causes of pseudo disc edema? The first thing that comes to mind is an optic nerve edrusion. Also, there can be myelinated nerve fibers or a tilted disc or a small hypermetropic disc or optic nerve hypoplasia. So here, side by side, I have given a picture of 2 fundus photographs. Here you can see in the first picture, it's a normal looking cup with very clear disc margins. You can see a central lighter area, which is the optic cup, and the vasculature all around is pretty normal. So it can be suggestive of a normal disc. On the other side, you can see that there is a C-shaped halo, which is kind of blurry. The margins are not very clear. And according to Fryson's grading, if we investigate it further, this might be suggestive of grade 1 papilledema. Now coming to these two pictures side by side, here you can see that we have a kind of lumpy, bumpy appearance within the optic disc in the first picture with blurred disc margins. What can this be indicative of? It can be suggestive of an optic nerve drusen. And in the other picture, you can see that it is kind of a disc. The disc is hyperemic. Also, the margins are not at all visible. There are splinter hemorrhages. This can indicate possible etiologies like AION, which you will have to investigate further with ancillary testing. Please read up on that when you get home. And this one is the Fryson's grading of the papilledema, which I will not elaborate further because of paucity of time. Now, these are a few of the tests which I'm sure all of you know. How to evaluate optic nerve function. Check for the relative afferent pupillary defect. Check for the visual acuity, the color vision, the red desaturation. Check for the visual fields. Check for the contrast sensitivity. Now, in a nutshell, talking about the diagnostic approach, I cannot stress enough on how you cannot underestimate the power of a good history taking. Listen to the patient. Go for the thorough fundoscopic examination. If there is unexplained optic disc edema, it will necessitate further imaging. Management, after all, will depend on the causative agent. Main complication which is encountered in most of the cases is permanent blindness secondary to optic atrophy, and that's what we're trying to prevent in these cases. And coming to surgery, many of these cases which involve an IXOL may need a neurosurgical intervention. So here, in the spirit of giving back to the society, I would like to share a video of a case operated by my mentor. Here you can see there's an optic nerve sheath fenestration for benign intracranial hypertension in a case of bilateral papilledema. Here we're using a navigation guided protocol for the same. And here, I will just jump to the salient points because of the paucity of time. Here you can see that there is a sudden release of CSF after giving an incision into the optic nerve. And then we are creating an opening in the durameter of the optic nerve sheath. And then after that, here you can see that these are the post-op results. See. So these kind of surgeries are pretty promising, and all of us should try to create more innovation for the same. So basically the take-home message is you should not miss an optic disc swelling on fundoscopic examination, and since the range of differential diagnosis is so extensive, you have to have a very thorough workup and investigate further. Do not exclude optic disc swelling even if the visual function is normal. That's the most important mistake that we make, especially as a beginner. And lastly, you treat the underlying cause, and just remember, timely diagnosis helps in better prognosis and at times is even life-saving for the patient. So thank you for your patience.
Thank you very much, madam. But your class was very extended. People are feeling a little jittery about it. Okay, over to the judges. Yeah.
Ma'am, there was a short note which was asked saying what is the role of OCT in disc edema. Can you give me one point? Would you do OCT, ma'am?
Yes. In certain cases, like I had elaborated about optic nerve drusen, you might find that the architecture is very, it's not preserved. There's a lumpy, bumpy appearance in the OCT, and in case of papilledema, you might have a more smooth contour. So that is one of the points. Thank you for listening so well. Thank you.
Okay, marks 7, 6, 9, 7, 7. Okay, thank you, Dr. Jiniba Deb. Now, over to the second candidate from Kerala, Dr. Lisa. I expect the Telangana team to be ready on the other side.
Rolika, you can roll to the other side. Yeah.
Okay, you can start.
Good morning, young brains out there. I have company with me today. Alexa, please start my presentation. Connecting. Yes, you guessed it right. Today, I'm going to talk about artificial intelligence in ophthalmology. You can see our magnificent India with a fancy number on top of it. What does it mean? It is showing the population of India, 141 crore, and on the right hand of the slide is showing some ocular disease burden, which is huge, with just 0.02% of ophthalmologists to tackle the issue. And what are we doing about it? We are conducting camps, we are having our OPTs, we are rigorously training our PG students, but are we able to meet the needs of the country? Not really. So this is like a funnel model where there is a huge ocular disease burden and very few people get to the expert treatment. So there was a man named Alan Turing in 1950 who thought about a machine that can think like human. And here comes our hero, artificial intelligence. And on a day-to-day basis, we are using it, our Google, Alexa, Siri. But what is with AI and eye? Eye is a very special organ where seeing is diagnosis. You see the disease, you diagnose the disease. And every part of eye is amenable to imaging. And ever since AI has been introduced, there are multiple papers which are published on diabetic retinopathy, retinopathy of prematurity, ARMD, keratoconus, keratitis, dry eyes, whatnot, and many more. So AI can help us with diagnosis, prediction, screening, and grading of the disease. So these are some of the examples that I would like to show, which is done in the imagology lab of Amrita Institute of Medical Sciences, where you can actually automatically detect the microaneurysm, and that we can know when you're sitting for the laser, where to laser. AI will show you where to laser. Then and there you're getting calls on diabetic retinopathy to look for the screen of diabetic retinopathy. And have you ever thought we can quantify heart exudates? Yes, we can quantify, we have done it. So that will help us in the treatment progression. Now, this is a retina health calculator that we have developed where there are hundreds of images of fundus in their software, and patient's fundus photography can be put and that will be compared with these images, and the patient's bioclinical data can be entered like the HbA1c, the renal parameters, the duration of diabetes, and 5 years down the line what is going to happen is going to be predicted by AI. Now, I would like to have you all have a hands-on on this virtual reality headset over here. You can put it all on after the class, and then you can have a virtual reality tour across the eye as this girl over there is doing. And you can even have the hands-on the surgical experience. And the AI that we have developed, our software, will be able to help you with the training. But remember, having all said all this, AI is not a magic wand. It is just a tool to help you to reduce the ocular disease burden. Still, our clinical skills, our communication skills, our human empathy, ethics, human values, all this do still matter. And these are the learning materials that you can go through. Connection lost. This is exactly why I'm telling you, you cannot trust on these artificial intelligence or Alexa all the time because they can get lost. We need human brains still to run the world. Thank you. Any questions?
Alexa, can we have questions?
I think Alexa is gone now. It's the era of Chat GPT.
Big round of applause.
Okay. Between artificial intelligence and natural stupidity, what do you prefer?
Natural stupidity.
So any questions? You have to ask questions. You have been dumbfounded. No questions. Speechless.
Great talk and a great oratorial skills. AI is going to rule, and so is robotic surgery. You said a very valid point about human behind the machine. In which specific ways, other than communication skills and the human connect, do you put that into perspective?
In which?
In human behind the machine, even for AI reading, in which way, other than the patient interaction, would you put the humans? For the AI perspective itself.
Like you mean were the AI?
For the validation of the AI. For the validation of the AI, you need multiple images.
Yeah.
Okay, so
Yeah.
for that point of view.
Okay, can we have the marks? Can we have the marks by the judges, please? A 9, and a 9, and a 9,
and an 8,
and an 8,
and a 9.
And a 9.
Wow, great.
Fantastic.
Doctor, fantastic.
Big round of applause to Alexa.
You are coming here? With us? No, it's here, free. Okay. So can we have a team from Bihar to be ready on this side? The second candidate? They have. लिखा नहीं उसमें, they will.
Dr. Rani Jamil, will be talking. She's from Delhi, and she'll be talking to us on Aqueous misdirection syndrome. Over to Rana.
Just before we restart the timer, just restart the timer, just 10 seconds more. We have the Entod quiz, which is going to be directly after this session. So all of you stay glued to your seats. And after this session, then the Entod quiz will start.
Lot of prizes to be won, lot of fun, lot of entertainment, lot of education in the next quiz that is coming up. Yeah, over to you, Dr. Rana Jamil. You can reset the timer, please.
Good morning, students. As we have already discussed the basics of aqueous, primary angle closure and open angle glaucoma in our previous class, we will discuss today aqueous misdirection syndrome. It is also referred as capsular block, ciliary block, malignant glaucoma. It is a rare secondary angle closure glaucoma, but it is a serious and sight-threatening condition, usually occurs during or after a glaucoma surgery. It is challenging to treat with uncertain prognosis. The risk factors are hyperopia, pre-existing angle closure glaucoma, recent surgery, and biotic therapy. Now coming to association, there are various conditions associated with this which are enlisted below, but it classically occurs after incisional glaucoma surgery for angle closure glaucoma. Various theories has been put forward regarding its pathogenesis, but the most accepted theory says that there exists an anatomical abnormal relationship between the ciliary body, lens, and anterior vitreous face, which leads to the posterior diversion of aqueous into posterior segment, leading to posterior pulling of the aqueous, which exerts pressure on the anterior hyalid face, leading to forward displacement of lens iris diaphragm, which is clinically seen as a uniformly flat anterior chamber and raised IOP. Actually, it is diagnosis of exclusion. It can occur intraoperatively and days to months after surgery, even months after surgery. It presents with non-specific symptoms of raised intraocular pressure like pain, nausea, cloudy cornea, decreased vision, and halos. The signs are uniformly shallow or flat anterior chamber, elevated IOP, which can sometimes be normal in the presence of patent PI and closed angles. Diagnostic procedures like USG, B-scan, ultrasound biomicroscopy, ASOCT are advised to rule out the differentials which mimic this condition, and it is a diagnosis of exclusion. Differential diagnosis for post-op shallow anterior chamber, which needs to be differentiated from aqueous misdirection or suprachoroidal hemorrhage, which is excluded by fundus examination, and if the cornea is cloudy, we have to go with B-scan ultrasonograph to rule out suprachoroidal hemorrhage. Pupillary block glaucoma characteristically present with iris bombay and posterior synechia. Choroidal detachment can be excluded by USG B-scan. Overfiltration on slit line examination, well-formed bleb, absence of leak, and on wound leak can be excluded by serial test. There are 3 management options for this condition. Medical is the first line of therapy. To reduce the intraocular pressure, aqueous suppressants and hyperosmotics are given, cycloplegics with atropine and steroids. It is effective in 50% of the cases. Laser therapy is given to patients refractory to medical therapy in pseudophakic and aphakic eyes. Anti-YAG laser to disrupt the anterior hyalid face, and argon laser photocoagulation of ciliary process has also been described. Surgical treatment, the goal of surgical treatment is to make the eye unicameral. The surgical treatments are pars plana vitrectomy with iridozonular hyalidectomy in pseudophakic cases and with lens extraction in phakic cases. The management protocol, the flow chart, we have to keep it in mind always. Management of fellow eye is to be seen. High risk cases, there is high risk in fellow eye. Prolonged use of cycloplegics are advised after surgery, and we can consider vitrectomy in high risk cases during cataract surgery. Thank you.
Thank you, Team Delhi. Now over to, sir, any questions for, sorry, question padega.
Atropine, how long do you give to this patient, and what are the cautions you'll take while giving atropine?
In some patients, it may have to be given indefinitely, for indefinite time.
Precaution that
What
you
is the precaution you take when you're using atropine for aqueous misdirection syndrome?
Precautions in aqueous misdirection?
Talk to me after the class.
Okay.
You teach her after the class, no?
Okay. And just a point
let's have the marks, please.
Marks 6.
5 and a 6 and a 5 and a 6 and a 7.
Just a word for postgraduate, never use the word malignant glaucoma. You better take it out of your thing, because when you say malignant glaucoma, patients will actually, they will Google malignant and they will think it is something to do with eye cancer. So always use the word aqueous misdirection or ciliary block. That would be a good idea. So now we have team Bihar. The hostess is here, Dr. Neha from AIOCMTC1.
Good morning, class. I know you are pretty exhausted by till now. This is the last lecture, and I want you all to empty your cup to regain the macular function test, which is very important for your theory point of view. Now, before starting, I want to share the anatomy of macula. It is a 5.5 mm circular area at the posterior pole of retina inside two temporal vascular arcades. Why it is important? It occupies the central 15 to 20 degree of visual field and is concerned with the photopic and color vision. It has 4 parts, as you can see in the diagram, and it has also the spatial anatomic configuration by having the densest concentration of cones, a 1-to-1 photoreceptor ganglion cell relationship, more elongated and slender cones, absence of rods, and presence of xanthophyll pigment. Now, how does the macular disease present to us? It presents to us with central vision impairment, metamorphopsia, micropsia, and macropsia. Now, we will deal with the main topic, that is macular function test. It is divided into 2 parts, with clear media and with opaque media. Now, coming to macular function test with clear media, the first is from simpler we will start, like we will do visual acuity, contrast sensitivity, slit lamp biomicroscopy, color vision, then photo stress, Amsler grid test, 2-point discrimination, 2 highly complex tests like microperimetry, FFA, and OCT. And now coming to macular function test with opaque media, we will again start with simpler tests like Maddox rod test, B-scan, then we will proceed to complex tests like focal ERG, VP, laser interferometry, potential visual acuity meter, and entoptic phenomena. Now I will discuss the main test and how it is used. Why it is used? It is used for diagnosis and follow-up of macular disease and also for evaluating potential macular function in eyes with opaque media such as cataract and dense vitreous hemorrhage. Now coming to first simpler test, 2-point discrimination test. The patient is asked to look through an opaque disc perforated with 2 pinholes behind which light is held. It can be done bedside also. The holes are 2 inches apart and are held 2 feet away from the eye. If the patient can perceive 2 lights, it indicates the normal macular function. The second is Amsler grid, which evaluates the 10 degrees of the visual field centered on fixation, and it is also useful in screening and monitoring macular diseases. Presence of abnormalities like blurred areas, holes, distortion, or blank spots are noted. Patient with maculopathy reports that lines are wavy. Patient with optic neuropathy remarks some lines are missing or faint. Maddox rod is combination with a bright light source is valuable darkroom procedure for assessing macular function. The main limitation that it can be used when patient don't have totally opaque ocular media. Now coming to photo stress test, BCB is determined An indirect ophthalmoscope is held 3 centimeter away from 10 seconds. The recovery time is for normal eyes is 15 to 30 seconds, and more than 50 seconds is indication of macular disease. Microperimetry, it can be done with or without pupillary dilation. There are two main types, scanning laser ophthalmoscope and MP1 microperimetry, which is more better. And now coming to laser interferometry, the main limitation that it is subjective, over predicts visual potential in AMLAX, and laser fringe vision is more better than vision of later acuity. Potential vision acuity meter has more advantage because it is easier than laser interferometry. Entaptic phenomena, the main are 3 types, and thank you.
Thank you, Dr. Neha. That was an excellent talk. We learnt a lot. I think students, any questions to ask for Dr. Neha?
Right from clinical to technology she has covered. Any questions to ask?
She's the penultimate speaker. We have the last speaker there, up there from Telangana. Any questions?
Any electrodiagnostic test which can be used as a macular function test?
Sir, pardon?
Electrodiagnostic or electrophysiology?
Electroretinogram we can use for macular.
Very good, very good. The last speaker for today in our Teachers of Tomorrow session, which has had us glued in our seats for the last 3 hours, is Dr. Rolika. Can we have the marks, please? 5 and a 6 and a 5 and a 7 and a 7.
Okay, we have the last speaker of this talk, Dr. Rolika Bansal, representing Telangana. So with her talk, we will be compiling the marks and we'll be coming out with the mark sheet. The best teams, number 1, 2, 3, who have fabulous prizes, cash prizes also, and a good certificate to carry home. And also the best tots, who are the best individual speakers in this Teachers of Tomorrow. 1, 2, 3, we will have. Right now. We'll announce right now. And all these cash prizes and certificates and all this will be awarded in the annual conference Kochi. Gopal will take care of that.
About 1 lakh rupees to be distributed.
And the local organizing committee will add some more money and Kochi.
Why not? The judges should be taken care of, no?
Is it okay? Are you ready with Dr. Rolika? Can we roll?
Yes.
Yeah, roll.
Just a second. Okay.
That is what I
So
said, no?
this happens to be the last class, I believe, and I guess your brains are as blank as the screen. And this was exactly how my brain was 24 hours back, because the heads of the department have decided to give me a topic on. Okay, this is not moving now.
It's still blank.
It's not moving. Just 1 second.
Can we have the timer on again?
Sensor.
IOL technology.
Sir, आपका topic है sir. कुछ भी
No, can we have the timer start again, please?
Okay, so I'll start again. So as this is the last class and your brains are as blank as it gets, as mine was 24 hours back, because the heads of the department decided to give me the topic of intraocular lenses, and that's how I filled up the intraocular, my brain with colorful world of intraocular lenses, and I will be talking on the recent advances in the IOL technology. And so being an oculoplasty surgeon, I am very unfortunate that I have no financial disclosures to declare. I wish I did. As I was going through the premier IOLs, I have a glimpse of your world. It's quite interesting. So Albert Einstein has put it forth that it's all relative. And what do I mean by that? It's all relative because Harold Ridley was the first one to implant the IOL in 1952. And even then, back then, he said it's a recent development.
So development and recent advances are all relative to time, and even then it was a new operation, and every single day we're pretty much evolving into a newer world. So first generation, second generation, I hope you all are prepared for the class and you know what these mean. And moving on to the 8th generation we have reached. So this is the way the IOLs have evolved, and I think it's a pretty good glimpse of how the evolution has occurred and how it has been a new light to all our patients. From 1949, from first PMMA lens, we have gone to 2017 of light adjustable lenses. The materials have evolved from rigid to soft lenses. The optic design has gone from monofocal to multifocal. The haptic designs have gone from plate haptic to plate loops. And the IOL designs are basically becoming smaller, lighter, and with better biocompatibility. Let's not talk about aspheric lens, really not recent, pretty much age old. So the journey has gone from monofocal to toric, monofocal plus, multifocal, extended depth of focus, EDOF, or trifocal lenses, or a combination of multifocal plus the EDOF lenses. So monofocal lenses are the ones which provide us an intermediate range and intermediate vision with no dysphotopsia. Extended depth of focus, they give us good intermediate vision, fair near vision, and minimal dysphotopsia. And then come the trifocal. We take care of all three, near, intermediate, as well as the distance vision. And then there are continuous range of vision lenses as well, so which give us a broader spectrum. Surface modifications have occurred. We have taken care of complications in various ways, and new optic materials. Let's go to recent advances of imagination. Injectable intraocular lenses, how cool is that? So we put a liquid state, and the liquid state material solidifies and remains in liquid form by various curing methods. And the shape memory intraocular lenses are pretty much in work. External stimuli gives an irreversible shape change, and 3D customized lenses are also available. We all know about light adjustable. India is looking forward to getting them. It has been there for 10 years now, so I hope it comes back to us soon. And we have been able to give a post-operative adjustment of 2 diopters. Drug-loaded IOLs are also quite important, and ozone-coated are fortunately available with us. So to conclude, newer multifocal IOLs are far better than the initial releases. Advancements in technology shall lead to higher cost for the patients, we know that. Adjustable IOLs are the near future promises and hope, and despite achievement of near perfect post-operative results, the search for the perfect IOL continues. But this is not my conclusion. My conclusion is I hope in IOL 2025 we have laser focus, we have a 5-dimensional vision, pretty much let's be Tony Stark out there, and we can have, like, say, app-based zoom in. Why not sit on a beach and let's see what's happening on the other island as well, and I hope we cut down the cost. I know that might not happen, but one can only hope. Thank you so much.
Thank you, Dr. Rolika. That was great. Dr. Tityal observed that she said something unique which nobody had told. She said, I have no financial interest, so you will not be eligible for the cash prize if you win it. So one question from you. Sir, IOL technology.
No, she did a great job as a teacher. I think we learned so many things which, students should know about these things. Only thing I would like to ask you, ma'am, recent advances wise, with the new generation trifocal lenses, which is that property which will increase the light transmission through the lenses?
So it's the structure.
Because we do have multifocality in these cases. They decrease the contrast because transmission doesn't get to the area.
Correct.
So how do we increase the light transmission through these lenses, ma'am?
So from what I understand, it's because of the shape and the coating that leads to the changes. So if I'm not wrong, I will go back and read.
I can understand why you are a truly oculoplasty surgeon.
Yes.
Can we have the quick marks? 9, 9, 7, 7, 8. Okay? Okay. Thank you very much, all the taught. That has been a great show. I think a round of applause for all of these bright young kids who are really shown that they are no less than the faculty. Dr. Yes, a standing ovation just to wake you up all again from this. We have been speechless and we have been sitting here glued for the last 3 years. Dr. Lalit Verma, sir, will actually give us some insights about the program that he just saw.
No, wonderful concept by Chairman Scientific Committee Partha Biswas. You see where we heard 26 speakers from 13 states. You see, what I thought was, so if you have to win these team prizes or individual presentation prizes, the topic should be very, very good. You see, today's world, you don't have to be only good, but as we saw here, I don't know what the marks at all, what marks are, coming up, but topic should be good, relevant. Besides the topic, I think your auditory skills and presentation also have to be very, very good. So because this changes the scenario. And I would also advise that topic should be practical also. You see, this appeals to judges also and everybody. And it should be futuristic and preferably in the area of their interest. So I think with this, some remarks, let's have the marks in case. So we have, prizes, two categories, best team as well as best, teacher or best taught. So 1, 2, 3 winners are there. So we have for winning first position 50,000, winning second team 30,000, and winning or the second runner-up winning team is 15,000. And best teacher for tomorrow, first position is 30, best teacher first runner-up is 15, and best teacher second runner-up is 10. So can we have the marks?
Yes, sir. I want the...
Yeah, take this.
As you're all anxiously awaiting the result, it's all ready, and this has been a great show. Please, the people who have names I announced, please come here, take a photograph with sir and all the faculty as well as the judges who actually troubled you for last 3 hours. So, in the descending order, the best team, state team. No, in the descending order. So, in the ascending order, okay. The 5th place, the best team goes to state of Telangana. A round of applause for Telangana. And the 4th place, best team goes to Orissa. And the 3rd team, best state goes to West Bengal. And the 2nd place is backed by state of Karnataka. And the first team, any guesses? Kerala. That is where you are heading for your conference, beware. Khana nahi milega. So, all of you please come over here and we have the... Yes.
So, we know why Kerala won, because this program was started and conceived in Kerala.
Most important reason is what Tital said. We have to go there. नहीं तो खाना नहीं मिलेगा.
But outstanding, Lisa and Alan, outstanding.
And still cash prizes to come for the best TOT, the best taught, the best individual speakers. Surprisingly, or not so surprisingly, they have been actually all have been tied up in all 3 places. So they are going to share the money, okay, share the loot. The 3rd place, the best taughts, has been shared by 2 bright taughts, Dr. Tasmiya and Dr. Rolika. Tasmiya from Karnataka, Rolika from Telangana. So they will share the 3rd best taught prize. Let them please come. Okay. Upar jate. I think, please, can we all go on the stage, because we will have better photographs. So the 2nd best taught team, the best taught individual scores, and it is shared again by 2 people, 2 bright taughts, Dr. Himani from West Bengal and Dr. Ashwita Alva from Karnataka. Yeah, please go on to the stage. Dr. Ashwita and Dr. Himani. Best taughts, first place. I think there is no problem to share between them because they both belong to the same state. They have traveled together. I think they will share the prize very easily. That is Dr. Lisa and Dr. Alan from Kerala have bagged the best taught award. 39. I mean, I'll just.
Mike?
Huh?
In the wings, we'll call you. He got 3 9. In the wings, we'll call you. KP, the president is overruling some rules. So it's the presidential call.
No, I was so impressed with, these talks. So it's not an overruling. My suggestion to the scientific committee and the panel of judges, honorable judges, is that sharing should not be done. You see, each individual should be given. I'll request Chairman Scientific Committee to, please listen to this. You see, whether it's the first position you announced, KP? Shared between Lisa and second person was? So they should be given that amount rather than sharing half and half. Because they have done, so whether you call it overruling or whether you call, this is my suggestion. Because they have worked very hard for the last so many weeks, and you see mentors also have to be applauded for that. But I do not believe in sharing of that money. Right. What do you say?
Done, sir, done.
Okay. So there is another candidate for the third place, tied at a third.
Second place, I think 41 he got, Ashish Majumdar.
So, but these have got 42, sir. So the third person tying up for the third place, best odd, is Dr. Ashish Majumdar from West Bengal. Dr. Ashish.
Oh, so we have a tie in the third place.
Third place also, 3 people. So you need to increase the cash prize next time.
Sir, since you have already agreed to double the amount, now it's going to be tripling the amount.
No, the question is, you see, because these kids, we can call them, they have worked very hard for that. You see, giving them a small token money is not relevant. So let's give them the original prize only. So we will, whether it is from AIO side or whether it's from AIO side or from, sponsored money, I still believe that sharing will be there for announcement, but the prize money will be individual. So that's what my suggestion is.
So there's one more tie for the second place also.
So
This is what I said. Now there'll be 4 ties at all places.
Dr. Janikson Jairaj from Orissa is again for the second prize. Please come over.
So,
Sir, paisa bahut kam pad raha hai.
KP, question is that last minute jugglery is not allowed. This last minute jugglery, what you are doing is not allowed. So that is what is.
The 3 who are supposed to be there.
The score sheets are here.
Let's
Yes, sorted.
In any case, all of you should applaud the effort of these people. You see, all of you applaud the effort what has been done by Partha Biswas, honorable judges, and all the mentors and mentees. Let's applaud the effort done.
Third, ho gaya na?
Yeah, okay.
Next announcement, no?
Which one? No, done. All done.
So, winning.
So you have to just tell where to collect the money.
Ek karke bulao.
Okay.
Let them take a photograph and then, they can.
So just for the photo ops, now we'll just call the best team, state team Kerala, Dr. Lisa, Dr. Alan. Come over, photographs. Your state people can come and take the photos from their mobile.
You should call the mentor also.
Mentor.
Mentor.
Srini.
Mentor is left.
Mentor, Gopal, you can come as a mentor.
Wait. Come.
Gopal is as good as a mentor. Gopal is a tormentor, actually, but we'll call him a mentor.
Stand in the middle. Take photographs and fatapat.
ड्रामा देख लिया ना
Thank you. Now the
Yeah.
second.
The second team, Karnataka, Dr. Ashwita and Dr. Tasmia. Mentor, Dr. Deepti Joshi.
Deepti, where are you? Thank you. Congratulations. Come and stand here.
The third team, Team West Bengal. Dr. Himani, Dr. Ashish.
There.
In between. Center stage. And I'm Dr. Sugato.
Yeah, Dr. Sugato, the mentor. So we'll quickly have the best thoughts. We'll have all at once. Dr. Lisa, Dr. Alan, Dr. Ashwita, Dr. Janix and Jairaj, Dr. Tasmia, Dr. Ashish, Dr. Rolika. Please all over come here.
Top three, no?
No, no, push me. Saath mein, sab aa jaiye. We'll have at once.
Come.
You're all tight. Come.
Alan and Lisa, no? Top. Alan and Lisa top, no?
Yeah.
Right. Photograph. Yeah. Fairuz, take a photograph. Oof.
Fairuz will not take a photograph in which she is not there.
Next. Okay. All done?
Okay, so from Dr. Gopal and myself, Dr. Krishna Prasad, we are thankful for AOS, especially Dr. Partha and his team, for this wonderful opportunity, and thank all the mentors and the mentees for their great cooperation. Thank you very much. And the judges finally for all the tireless effort they did and for judging this competition so fabulously. Dr. Gopal.
Thank you very much. And it is really an amazing thing. This is the first time AIOS is witnessing it. And next time, I hope this will become bigger and bigger and bigger. And the prize monies will also grow